Good morning, everyone. Welcome. We're so pleased to have you join us today for our Data Science for Advancing Population Health Symposium, sponsored by the Berkeley School of Public Health and UC San Francisco and the Department of Epidemiology and Biostatistics. I just wanted to welcome you all today. My name is Courtney Lyles. Myself and many other great people who you'll see here today as part of the steering committee have hopefully put together a great agenda for today. We're going to have essentially 4 sets of speakers today, partnered from Berkeley and UCSF to talk through different use cases of data science for advancing population health to both spark ideas for future research, ideas in which maybe you all might be thinking about using some of these data in your own work. And then the second real major goal of today is to think about collaborations. So to bring all of us together from different campuses to think through what are the strengths of each of our campus and how can we work better together to leverage our methodological content area and other strengths to create great research and projects together. So thank you all for joining us. Hopefully you will enjoy what we put together. I wanted to introduce our keynote speakers for this morning to launch this event. We are very fortunate to have Kirsten Bibbins-Domingo and Will Dow to kick off their vision for data science and population health this morning. Kirsten Bibbins-Domingo is a professor and chair of the Department of Epidemiology and Biostatistics at UCSF, and she's also the inaugural Vice Dean of Population Health and Health Equity for the School of Medicine at UCSF. And Will Dow is the professor of health policy and management in the UC Berkeley School of Public Health and also the interim dean of the School of Public Health. And the two of them together are going to share individual remarks and then host a small conversation with you all about some of their vision for population health in this space. Thank you guys all for coming.
Great. Thank you so much, Courtney. So I'm Will Dow. I'm the interim dean of the School of Public Health here at UC Berkeley. I want to welcome everybody here today. Those of you who are from different corners of Berkeley, welcome. It's wonderful to be together. And those of you who are here from UCSF and our other sort of partners around the Bay Area, welcome. We hope that we have many opportunities for conversation and collaboration today. There's so much exciting work that's going on in this space around data science and population health around the country and around the world, but particularly right here in the Bay Area. Those of you who are here, thank you for being here first thing Monday morning, and congratulations for getting a seat. We actually have about 100 people on the wait list. We have an overflow crowd that is going to be in Berkeley Way West. We are filming this, so I anticipate as the morning progresses, we'll have more people trickling in. It is also Earth Day, so happy Earth Day to folks. There'll be all sorts of events downstairs here later in the day, but I'm glad that you're spending your Earth Day here with us. Just to echo what Courtney said in terms of the goals of the day today, really it's to cross-pollinate ideas amongst all of the different groups that are doing work in this space around the area, both within Berkeley, within UCSF, and across the campuses, and again with all of our partners. So the more that we can help facilitate introductions between folks who are doing work that relates to each other, we want to see that exchange of ideas, data, methods. We'd love to see more, better research coming out of this. So to the extent that this leads to new methodologies being shared, new applied research being shared, that will be a huge success. And the larger vision for this, though, is really to think about how we can pull together data science and population health around the Bay Area. Sitting where we are, adjacent to Silicon Valley, we should be known as the premier place in the world in this space. And we have many great individual things going on, and we have many great collective things, but if we actually brought all of these assets together, I think that we indeed are one of the greatest areas in the world right now doing this work, but I think that we could really go to the next level, and that is sort of the call to action today, right? Not thinking about where we're sort of competing and stepping on each other's toes, but looking for all of those areas of complementarities where we can leverage these complementarities. One of the areas, as Kirsten and I were envisioning this, was to really think about how we can focus on population health here in California and focus on some of our most vulnerable populations here in California, where we have a joint mission to really help think about how we can improve the health of the population, the whole population, and that necessarily implies focusing on our most vulnerable populations. So I'd love to see conversations about that intersection. So Kirsten and I are going to lay out a bit of the sort of broad agenda here, and I think keynotes is probably a little bit grand of a word for how we're going to launch things this morning. And then we do have these sort of 6 talks from fabulous folks throughout the morning. As we were thinking about putting together the program, we thought, well, there are about 100 different talks that we could have today. And of course, we could only choose a handful of people, but we'd love to see this be the start of many more such events going forward. So we will look forward to your feedback about how we can develop more such events, what would be most helpful for you. We also want to make sure that there's plenty of time for discussion, both formal discussion at the ends of each of the sessions, as well as in between. So finally, just a few thank yous before we get started. In the back is Elizabeth Brashears from the Vice Chancellor for Research Office. So thank you for doing so much to help get the support from the campus, as well as from the Correct Foundation, who's provided funding for this event today and for many other similar activities that are going on in this space. On the Berkeley side, I want to thank Jen Ahern, who's our Associate Dean for Research at the School of Public Health, for all of the work she's been doing to help to organize this, along with Mahasan Mujahid, our Associate Professor in School of Public Health, and Lauren Goldstein, who's helped on the staff side. I know that there are many, many people at UCSF that have helped to make this happen. So Jessica Fields on the staff side, thank you. Rita Hamad. And then Courtney Lyles has really carried the water on a lot of the program planning. So thank you to Courtney. And then finally, I want to thank my collaborator in thinking about the vision for this event, and that is Kirsten Bibbins-Domingo, who will come up here now for the first keynote. Thank you.
Perfect. Thank you. Do I have to get out of this? Sorry.
No worries.
All right, so I am thrilled, and I'm going to extend my words of welcome to all of you who are here, who are watching us on live stream, who are in the overflow, and who are hopefully on your way here. It's really exciting to come together for this topic. You know, as Will said, we are oversubscribed. We have an interesting cast of characters here. We have people who are staff, faculty, or students from UC Berkeley across a range of disciplines. Same, staff, faculty, and students from UCSF across a range of disciplines. Somehow somebody let people register from that school in the South Bay that has a tree as a mascot. We have people here who are leaders and practitioners from UCSF Health, from Kaiser, from One Medical, from UCOP. And I think it really reflects the broad interest in population health and in data science, and the potential for the types of interesting interchange that we can have by discussing what these concepts mean to us. So I thought that I would begin my remarks by reflecting on the sets of words that brought us here, population health and data science, and reflect on what these mean in the broader landscape of things that are happening, and hopefully stimulate at least what I hope is what brought you here and what might lead you to conversations with other people. So for a definition of population health, one that's certainly popular in the medical literature right now is from David Kindig, the outcomes of a group of individuals, including the distributions of such outcomes within the group. Another definition here by Sandra Galea, Dean of the School of Public Health at Boston University, when it describes population health science as the study of conditions that shape distributions of health within and across populations, and of the mechanisms through which these conditions manifest as the health of individuals, right? Pretty good definitions. But I want to step back for 1 second and just reflect on this. So if we think about what is traditionally viewed as the public health model and the medical model, it is completely obvious why people from the School of Public Health are here, and perhaps not at all obvious why people from UCSF are here. Or why the medical model, which generally has thought to focus on the individual, really should be thinking about or is talking about the health of populations. And I just want to reflect on the several trends, as others have, of why medicine and schools of medicine are talking about population health. So, and these are not mutually exclusive or meant to be exhaustive, but these are certainly trends that are here. A large trend, of course, is understanding that the limitations of what of our achievements versus health metrics when it comes to our investment in the healthcare sector. The second is increasing awareness of social determinants of health. So when I started on faculty as a researcher 15 years ago in health disparities, a smaller community of people were talking about social determinants of health, and now virtually everyone says social determinants of health are important for healthcare. There is a recognition among people who write about and talk about health system performance that health system performance really depends on improving quality of care, achieving health at the population level, and reducing the cost per patient in order to do this. And there are financial incentives that align now, as we think about value-based models of care, that increasingly ask us to think about health at the population level. And I would say there is probably more willingness than there has been in the past to identify, test things that sit across sector, across discipline in approaches to achieving health and prevention. So, this is an interesting time. It's a good time. I would be remiss if I didn't also say that for some of you here, population health has a different definition than for others. Because within the medical model, oftentimes population health is about the health of the populations for whom we are caring. And that is very different from the broader definitions of population health that some of you in the audience are probably thinking about. And what I would argue is that while that distinction is an important one to understand, it is not one that should prevent us from having conversations. Because really, medical systems that are thinking about the health of the populations they care for are increasingly doing things like investing in community approaches to achieving health, investing in housing, investing in food, investing in transportation. And some of these approaches in some settings are leading to improvements in population health for the broader population beyond the population for whom they're caring. These are the trends that are happening. What I hope is that we understand the nuances and the differences, but what I would argue is that population health is actually a very interesting space right now that is bringing together people who think on the medical side and people who are thinking traditionally on the population side in a way that I'm optimistic about advancing population health. The second term that I'd want us to talk about is data science, because this is sort of the glue. This is the innovation. This is the time where advances in how we think about data, the types of data, advances computationally and in allowing us to do things faster and in more interesting ways, have really stimulated the interest of applying these tools to the goals that we have to advance population health. And while you're going to talk about today about many types of data within this sphere that might be important for advancing population health, I want to focus now just on the clinical data because that's one of the things that I think is very exciting about how that enters this particular arena of population health. So the first way I just suggest to you and remind you is that at UC Health, the 6 health systems that are associated with our sister schools all take care of patients, and there is a massive effort underway to actually bring together the medical records across these 6 health systems onto a single platform that would allow us to really draw new insights into how disease progresses, what predicts particular patterns of disease. This is a slide from my colleague Atul Butte, who's the director of the Baker Computational Health Sciences Institute and also the UC's chief data officer. And this is a grand undertaking, but when you think about 15 million patient records, apparently at UC we take care of 5% of the US patient population. This itself is an extraordinary effort and future achievement that will really, I think, allow us to have important insights across California and the populations that we serve. Another important effort is to think about how we are sharing our data. So this is from the Department of Public Health in San Francisco, which is part of the Bloomberg's Partnership for Healthy Cities. And these are cities around the world that are thinking through novel ways to partner in order to improve population health. And in this case, this is partnering with data sharing to allow the city in San Francisco to actually better surveil non-communicable diseases. While we have good models for reporting many diseases, things like diabetes are actually, the departments of public health are relatively blind to diabetes because there's no way to capture them. And so the city has undertaken a grand effort to get health systems within the city to share data around common chronic conditions that can allow them to do better surveillance. In the first one, I described this as a grand undertaking. This one might not be as technically complex, but getting 5 health systems to share data is as much of a grand challenge as the first one, I would argue. The last is trying to think of how we, in fact, are using our data within our setting, how we think across dimensions of data. I'm going to give you an example here from Cincinnati Children's Hospital, but you'll hear more about our early efforts at UCSF to think in this way as well. So at Cincinnati Children's, they took their patient records and through geocodes, lat longe of their patient addresses, also linked to understand the psychosocial environment, the economic environment, the physical environment, and then the types of other medical services that were available to their patients. They're driven by the questions that health systems care about. How do we reduce readmissions for asthma, things like that. But this linkage has led to some very interesting sets of interventions. So in this case, they were looking at readmissions for asthma. They found, as you probably are going to immediately intuit, that many of these readmissions were taking place in areas of the city that were lower socioeconomic status. What was important for them as they mapped where these readmissions were happening was that they found that there was a big hotspot in a single apartment complex, and led them then to intervene on that apartment complex rather than doing one patient at a time. And so an important way in which using their data has led to them thinking about improvements in health beyond that individual patient. This is how they've mapped their inpatient bed days and allows them to look at the types of diagnoses that are increasing their inpatient bed days. And this is stratified then by the poverty quintiles of the area in which that patient lives, and allows them to focus on certain types of conditions and to think in the environment in which these inpatient bed days are occurring, what other things that are important for interventions can they think about in those environments where these hotspots are occurring. Data is an important driver of this. This doesn't happen in Cincinnati without very strong partnerships, and there are many more things in their initiative. But they are using data to help inform the types of interventions and the types of activities that they're engaging with the community as well. At UCSF Health, we're very interested in building a knowledge network that acknowledges that these various domains of data together can yield important insights. So this is how we've built our information commons and are continuing to build it to understand these varying levels of information that are important for an individual patient. We're trying to think about how insights across these domains of data can actually enable discovery, can actually be used in real time to improve clinical care of patients. But as we also understand patterns for large numbers of patients to actually inform public health. And this is the strategy that we've outlined from the beginning, although this is entitled precision medicine. Our definition of medicine here is very broad to try to understand all of the domains in which an individual and populations of individuals actually how their health might be influenced by a number of factors. Here again is the information commons, our driver, our engine of the information coming together, and then thinking of here how we use this to understand how to improve health for individuals and populations, to accelerate discovery, and to advance innovation. And I'd invite you to go to our precision medicine website to read a little bit more about this. We've been thinking about advances in data science, computational advances that are oftentimes the engine that drives this word precision, precision medicine. In our term here, we use this term precision public health in a summit that we held in June 2016, sponsored by the White House Office of Science Technology Policy and the Bill and Melinda Gates Foundation. While precision public health certainly has its detractors and has its limitations as a term, I would say we were very interested in using a term that is recognized by many as reflecting the advances in computing, in data, in measurement, in integration of data that are possible now, and making sure that these advances could also be used to apply to some of our greatest public health and population health challenges. When we held this summit, it was a national summit. We invited leaders from different sectors from around the country and really had a very grounds-up discussion over what are the possibilities of this environment, this exciting, innovative environment that we're living in right now. And there were three themes that really came out of this conference. I'm going to point you to a paper written by Courtney Lyles where she describes these themes in greater detail. The three key themes here were, if we're going to really use data science to advance public health, population health, this has to start with a commitment to social justice. That we have to say that our goal here is actually to improve the health of our most marginalized communities. That has to be part and parcel with our efforts. I was recently learned that UCOP commissioned a group to look at ethics in our use of UC data, and they articulated from an ethical framework justice as the cornerstone for how UC should consider use of its data, and I was really quite heartened to hear that as well. The second is the power of data sharing. For many in the audience, it was important to note that if we're truly to realize the opportunities here with this new advent of data science, we have to think about data across sectors, across domains, and measuring data across multi-dimensions. This requires much more planning and governance. It requires development of trust and platforms to allow for data sharing, but this is essential if we're going to achieve the goals that we have. And lastly, the importance of community engagement, that we live in an environment where data is being used in positive ways, but data is also being used in ways that have the potential to harm individuals and communities. If we have a commitment to social justice, we have to assure that all of the communities that we are trying to serve are actually engaged and aware of our efforts and can really contribute to those in meaningful ways, both on the governance side and on the generating the scientific insight side. So I'm going to leave you with a thought from Dr. Tom Boyce, who's one of our leaders in early childhood development at UCSF and who gave the keynote at that summit. And I really love his insights, so I'm just going to quote them exactly how he gave them on that day. We were focused at that Precision Public Health Summit on how we could use data to improve the first 1,000 days of life. That was the focus and the frame of our summit. And so Tom said, public health and medicine have labored for centuries as distant, largely estranged health science siblings, each regarding the other with a level of vague suspicion and slightly moralistic derision. I won't poll to see who says that's true. But emerging precision science, and I would read here data science as a tool here in precision science, especially that addressing early childhood development, is now disallowing this familial disjunction, demanding a more convergent synthetic view that involves both public health and medicine. From this point forward, understanding and intervening upon the genesis of human morbidities will almost certainly require collaborative, interactive knowledge of both broad social and physical environmental exposures and individual biological variation and susceptibility to those exposures. And he ended with this graphic that basically says we need to have a more binocular view. That if we start with just precision medicine, we are often blind to the powerful role of social and environmental exposures. If we start from a traditional public health frame, we might be blind to individual variation and biological susceptibility, and that coming together only with a true partnership of precision medicine and precision public health can allow three-dimensional insights on how we might protect and sustain the critically formative first 1,000 days of life. I'm really looking forward to this conference. I'm really looking forward to the discussions that I hope you all will have with each other and to the great talks that will hopefully stimulate some of your thinking in this area. I want to remind you that we have just launched a website on population health, and I've referenced the other websites that might be important for you in this area. Now I'll turn it over to my colleague, Will.
Thank you so much, Kirsten. That was a wonderful way to set the stage for the conversations that we're going to have today. And if you're watching the clock at all, you will note that Kirsten and I have committed to each other to make sure that we end with plenty of time for discussion. So at the end of this session, before we get into the meatier presentations, we will have time for discussion. So be thinking of sort of conversation topics that were sort of missed or you want to make sure get inserted into the discussion today. So I just want to begin with a reminder of the sort of big picture health disparities that we see in our country today and indeed in our community. This is a map from actually a number of years ago of Alameda County, and we're picking out in Oakland in particular in this sort of middle section here, different census tracts with an attempt to measure sort of life expectancy by census tracts. You don't need to look at each individual census tract to see that there's a lot of color variation, and you don't have to see the individual numbers here. I will just pull out for you the summary statistic that there's a 24-year gap in life expectancy between the hills, the wealthier areas of Oakland, and some areas of West Oakland. We see this in many areas throughout the world, throughout our country, but we have it right here in Alameda County. And there are different measures that we could pull, different statistics, but we know that there's huge variations right here in our own backyard. And this is not just due to the fact that there's no hospital around for people to go to, right? Healthcare is super important for these people. There's so many solutions that healthcare can contribute to, but we know that prevention is one of the most important things that we can do to try to reduce these types of health disparities. And a lot of that prevention is going to be not just within the four walls, but it's going to be in the environment in which people live, work, and play. Right? So many of the risks that we have seen over time in the public health world are really related to factors that are much farther upstream. Okay, so this particular figure I pulled from a study about 10 years ago. We've known this for decades, that this is actually like this. We have increasing data over these decades and trying to understand individual risk factors, but what we haven't really had is the comprehensive data linking individuals to this larger set of risk factors out there. We have had many types of studies and interventions and policies that try to get at one individual or a few pieces of these risk factors, but increasingly we're going to have to think about these comprehensive solutions that are marrying primary care with public health, with larger social policies and interventions. And if we're going to be able to have these comprehensive types of approaches, we're going to have comprehensive data that are actually going to meld together our understanding of how these are all fitting together. And that is really the promise for how we can try to make progress on these really intractable problems that we have seen. So as we go forward, we have this sort of data science. And there are a number of different pieces of data science that we'll be talking about today. One is just massive new data sources that are coming online. So we'll be talking about some of those. Second is the possibility, increasingly, for linking across these different data sources. So not just better measuring each one of these, but being able to link the individual across all of these different types of measures. And then, of course, the methodological innovations for actually using these data. And then overlaid across all of these are the technological innovations that are allowing us to better measure, to better integrate, and then to better apply these types of data to new types of interventions, right? So let me just talk about some of the different types of massive data sources that we're talking about, and I want to highlight some that we'll be talking about here in some of the talks, and then, of course, a number of these, we just don't have time in the program today. But as Kirsten mentioned, one of the huge opportunities that we have is to better use data that is coming out of our healthcare systems. So we have healthcare claims data that we've tried to use in sort of isolation, unlinked to many other things for many years. We have the hope here in California, this perennial hope that we've had for decades, and there's always people that are ever so optimistic that we're going to get to an all-payer claims database sometime soon. I will cross my fingers. It's better to be an optimist, but we're not sure when this might actually happen, to have an all-payer claims database that could really blend together the data that we're getting from all of these different insurer types into one massive database for the state, which would be fantastic. But electronic health records, we have this progress that UC Health is moving forward with, and has such richer data above and beyond the claims data that includes so many different types of text fields, et cetera, that with our methods that we have that are coming out of data science, ability to actually mine these text fields is sort of tremendous, what we can potentially learn. Okay, and then we have a huge amount of research which is happening here in the Bay Area in particular around different types of what I will call biomarkers writ large. Some people will take offense to that term, but when we're thinking about genomics, there's so much that we can understand from genomics, right? There is and just massive amounts of data that we're learning from the genomics, and the ability to measure each individual has huge potential, as well as the epigenomics, really understanding gene-environment interactions. So where in the life course do we see the methylation patterns changing, for example, right? There's huge opportunity there. Exposomics, as we think about all of these different types of exposures sort of in the environment. Personal sensors that are able to capture biomarker information in real time that people are connected to. We won't be talking so much about the biomarker data today, but we will be talking more about geocoded data. So again, this is part of the opportunity for blending information from individuals to really learning about the places in which they're living. So some of this is happening at the level of sort of traditional survey data. so much is happening at the level of sensors that we can measure in much greater detail the exposures that people have. So we'll be hearing some more about the potential to better use administrative data from so many different types of government programs that are out there that we could be blending in. We have the potential for using social media data, so we'll have to talk about social media data. There's massive things that we can do using the data that are coming out of search terms, et cetera, that people are trying to use from phone apps as well as just many other devices and sensors. So there's so many different types of massive new data sources that are coming online that have the promise. The challenge, of course, is to develop the linkages across these many different measures. So the opportunity there is to link an individual over long periods of time with the data so you can understand the exposures across different parts of their life course. And so trying to measure their health outcomes from EHR data and claims and sensors, et cetera, linking those to the mediating behaviors, which we typically only measure in sort of surveys, but increasingly we're able to use phone devices and other types of apps to measure those. Then linking those to the social risk factors that are coming from those place-based sensors. Linking those to the policy interventions, right? Those are the opportunities, but the challenges are big. And this is where we all collectively have to be thinking very deeply about how to overcome some of these challenges. So one of them is the privacy challenge, right? We know this is huge. Those of you who have been sort of following the New York Times series that most recently on privacy, they are certainly scaring a lot of people out there who are sort of reading into this that didn't realize how little is actually private in their life today. And people are getting increasingly concerned. And as a research community, we have an obligation to think about how we can protect privacy and limit data disclosure. We don't have a talk particularly on that today, but that's always a very fruitful topic for conversation if people want to talk more about that. The legal structures surrounding privacy are in many ways quite dated. They're sort of slow changing that allow us to be innovative with these data in a way that could protect privacy in a sensible way, but actually changing those is very difficult. And then, of course, there's the technical issue with actually doing the linkages that unique identifiers in the United States are rare, except that our cell phones are turning into the de facto unique identifier that many people don't realize is the new social security number. But we don't have our cell phone numbers in all of the different types of data sources that we're trying to braid today. But this is really one of the big challenges that we have here in the United States that we know in Scandinavia and some other places we've been able to make a lot of progress from areas that actually have identifiers that can be shared across data sources in a sort of confidential way. So then, of course, we have the methods innovation, and there's many people in the room that are engaged in the methods innovations here at Berkeley. So machine learning is sort of all the rage, of course, and this is what we hear about so much, and there's so many different dimensions of machine learning. We'll have more talks about that, different aspects of that today. I won't spend a whole lot of time on that. But one of the really serious aspects of the methods that we need to worry about is measurement errors in all of these data. And as we try to apply machine learning to the data, we have the risk of amplifying measurement errors and baking in all sorts of disparities, baking in all sorts of problems as we try to use those. And that's sort of been well recognized, but we have a lot of work to do in how we address that challenge. And then there's the causal inference challenge. Okay, so we have all of these data. Increasingly, we can do randomized interventions and using these massive data sets, but we know that so much of the inference that we want to be doing is going to be using our traditional quasi-experimental types of approaches. But with the massive data sets that we have and integrating with the machine learning algorithms, there is a great deal of work to do to understand how we can push forward that methodology. And I'm very excited that a lot of that work is happening here in the Bay Area. And then there's the opportunity to use all of this data to better target individuals. So this is part of the promise of using all of this data, not just to be measuring what's going on, not just to be looking at sort of causal inference writ large at some broad black box level, but to really understand the characteristics of individuals or their families or the communities in which they live to help us target what types of interventions are going to be most effective for what types of people. And of course, we can dig in at the individual level, down to the genomic level, et cetera. There's so many different ways of doing this potentially. And then adapting those interventions to real-time feedback. Right? So this is where we can really get some potentially exciting leverage that we know that so many different types of interventions are going to wear off very fast. So as economists, we look at some of the behavioral economics interventions and we see fading of these types of interventions as people sort of adapt to data, and then they start to ignore the nudges over time potentially. And that's the risk. So how can we keep innovating and adapting to people, taking the signals about what people are actually responding to, and then adapting those interventions? So just a word about the sort of precision public health debate, which sort of Kirsten mentioned as well, and has been a robust debate within our public health community here at Berkeley. So many different definitions of what precision public health is, but as I see the promise really is using data science to target and then continually adapt public health policies, programs, interventions to those individual family community conditions so that we can have the greatest population health impact, right? So we're not sort of wasting interventions on sort of the wrong people. We can continue to focus that. But a lot of people are taking the term precision public health and taking exception to it because, again, as we get into this divide where there's sort of mutual mistrust among different types of disciplines that Kirsten was mentioning, many people think of the term precision public health and they think, well, this is all about genomics. And when we look at that map of Oakland, yes, there are genetic differences across individuals living in those different neighborhoods of Oakland, but that's not really what's driving it. Precision public health is going to send us down a rabbit hole to focus on all of the wrong things, right? Again, I don't think this is it's an either or, it's an and. We need to use all of the information that we can from all the best kinds of science, including genomics, but that's only going to be a sort of small part of the equation, really, the sort of genomic connotation. And I think we want to have a very expansive definition of what precision public health is, and I think many people get frustrated about the debates because there is so much opportunity here to be precise about our public health interventions. One of the big concerns, though, which is very real, is around access to technology. So as we read the history of science and technology, we know that so many technologies over centuries essentially benefit the least vulnerable much more, and they can exacerbate the disparities that we're trying to address. Right? So it's great that we have technologies that will benefit different people, but in the public health world, when we're trying to address this sort of 24-year life expectancy deficit in some areas of West Oakland, what we want to make sure is that we're not sort of ignoring the people with least access to the technology. So I think the challenge for us in the precision public health, precision population health world, data science and population health, is to think about what types of interventions have the greatest promise for harnessing data science to address the problems of our most vulnerable populations, where indeed the biggest health deficits are. So that is one of the biggest challenges. So we shouldn't throw out the baby with the bathwater, but we need to think about what is actually going to give us this biggest bang. And then those types of interventions, we need to figure out how to actually democratize those and make sure that they are getting to those populations who most need those types of interventions. So, as I see it, a call to action for our community, one is to democratize not just the interventions that I was talking about, but to start with democratizing data. Right? So many of us have our fingers on different pieces of the data, and we need to make a collective commitment to each other to think about how we can make sure that those data can actually be used and be blended together so that we can actually achieve some of the promise. And this is going to involve transcending our silos. Right? So our silos, we have many silos right here at Berkeley, and silos across institutions. We're going to have to work hard to transcend these silos. And we're going to have to harness those initiatives that are already ongoing. So Kirsten talked about some of the initiatives, and on the UCSF side here at Berkeley in our School of Public Health, one of our strategic initiatives is around data science, technology, and health, and we're trying to move forward in that initiative. And we're very fortunate that the campus is investing in this area as well. So the campus has invested in a new division of data science and information to try to bring together our assets across different silos. We have a long way to go to see how exactly this is going to play out, but this is a really unique time for us all to be getting together, and we're creating academic structures to be able to help break down some of those silos. And it's fascinating to see in the campus's current strategic planning environment, the Vice Chancellor for Research has been spearheading an initiative that's identified sort of 5 different major strategic initiatives around research areas. 4 of those 5 are directly related to what we're talking about. One is called Charting a New Course of Health and Well-Being, so that's an obvious one. Okay, and that has a sort of data science component of it that has been part of it, but is really cross-cutting across all of these different strategic initiatives. A second one is around equality, equity, and opportunity. Again, health is absolutely central to that. Inclusive intelligence. Everything that we're talking about, data science and machine learning, is part of this sort of inclusive intelligence initiative. And then environmental justice and sustainability with, again, the environment so writ large as being such an important part of these social determinants of health. So I'm just super optimistic that the campus is pivoting to what we all in this room care about. And so we have a really wonderful opportunity here to build on this. So I want to thank you in advance for all the conversations today, and we have a few minutes now for questions from the floor. Art Reingold, yes.
Thank you both for that. So I just wanted to make 3 quick points, not that obviously can't be dealt with today, but I think are topics for future conversations. One is you mentioned the importance of the legal and ethical challenges, and it seems to me that we need to bring in the political science, the public policy, law school types of people if we really want to make advances in those areas. Because those are certainly challenges that involve expertise in those areas. But 2 areas that I don't think have gotten much mention that I think are really going to be important moving forward. One of them is the partnerships with public health agencies. My wife tells me about once a week that people in academia don't do public health, people in public health agencies do public health. I'm glad to see some of our public health colleagues are here. Kirsten did mention the San Francisco Department of Public Health and work on diabetes, and that's great. But they have legal authority to do a lot of things that we don't. They have access and use data, and they have needs. And they also have needs for the interface between public health and clinical data that have a long way to go. So I think partnerships with people in the public health agencies and talking about those would be really important. And then the third point is clearly all of this has enormous ramifications for how we educate our students. Not only medical and nursing and other clinical provider students, but public health students who are going to go to work in all of these different types of settings and are going to need very different skill sets than they've been learning over the past decades.
Thank you for all of that. I agree. Those are all super important, and I'm very gratified that the campus conversations around inclusive intelligence have actually been much broader, including many of our sort of social science and humanities colleagues around that. Public health, I was glad that Kirsten mentioned our community partnerships. So community engagement, I agree, is absolutely essential to sort of moving forward and engaging with our colleagues in the public health departments is a super important part of that. And then around the around education, absolutely. And this is where I think the new Division of Data Science and Information has the potential for really helping to bring together some of our education initiatives across the campus here at Berkeley. So I don't know if you want to add to that.
And I just briefly just want to recognize Tomas Aragon, who's a public health officer for San Francisco in Division of Population Health, and we've loved our collaborations with the Department of Public Health and view those as critically important for a lot of this work. And then I will also say just the legal, ethical, social frameworks, super important. There's a report that UCOP commissioned that I don't think has been released yet that really starts to dig into this. And we have a group, I know Mark Pletcher is part of this, that has been batting around ideas around how to approach the framework and what we can contribute. If you noticed in the New England Journal of Medicine, there was a call for a new Belmont commission in the era now of big data. And I think for those of us in particular who want to use data to advance the health of the most marginalized communities, the onus is particularly on us to show that we're both figuring out how to protect individual and community rights, privacy within this regard, and using this in the most ethical and just way. You call.
Claire?
It's your...
Well, thank you to both of you for laying out a wonderful agenda. I just wanted to add a few more things, and building on what Art said about policy, which of course is really important, not only at the end of translation, but also at the very beginning, because policymakers also have a lot of questions in this area. But I want to do a shout out for qualitative data. I think it's very important to be laying qualitative data throughout as a DNA of all this data because of the importance of really understanding context and setting, et cetera. And then I think another big issue in the world of high tech, high touch is the really understanding such tremendous variation within community. I mean, apart from the nuances that you showed, is the fact that there are a lot of positive deviants. So even in these communities that are really fraught with many, many different socio-political, et cetera, challenges, we really have to understand that there are many people who are successful even within these very difficult situations, and we have to learn from them as well. And the final issue is I really think that we need to build a compendium of efforts that are successful interventions that have been working, because a big challenge here is that we're going to know a lot more about what the problem is, but people are really hungry for knowing, so what do you do about racism, and how do you really get under the skin, and what has been working and effective? Thanks.
Good. Agree. Yeah, thank you. Yeah, I won't take time by commenting. It's all very well said. So,
activities can be undertaken to build more bridges between universities and the state health department, where I and a handful of other people here are from, as well as the local health departments like San Francisco, where Tomas is from, but there are smaller, less resource-rich counties that could really benefit from those collaborations. And we have reached out a few times in different ways to try and get some, in a sense, academic support for some of our what is becoming, you wouldn't say old government data activities anymore. We are on you might not believe it, but we're moving towards cutting edge in terms of certain aspects of our data processes, but there are components of that that really would benefit from intense collaboration with academia. And again, it's hard to figure out where those what the mechanisms are for those. I will say the fact that we're not in Berkeley anymore, the state health department, has really been a problem, or sad, in terms of just walking across the street, classes that were much more involving of academics and whatnot. But nevertheless, I think there's lots of great opportunities. I will say that Davis has some interesting collaborations and sort of informatics folks with a number of sort of innovative data activities at the state health department, at least. But there's so many opportunities for additional collaborations, I think.
So thank you, and I will say that for those of you who haven't read the State Health Workforce Commission report, which came out a few months ago, one of the things that they highlighted is the opportunity that we really should be pursuing for building out academic public health departments, essentially a mechanism for creating these interactions. And I think that the onus is on us collectively to go back to the foundations and say, okay, help us make this a reality. Yeah.
We're open. We love the idea.
Will, you touched on access to technology, and a week ago, the governor spoke about 25% of the homeless in the U.S. are in this state, while only, I think it was around 10% of the population, or 12%. So they're the groups you're talking partly about that don't have, may not, some percentage of them don't have medical records in hospitals, don't have social media access, don't have. How are those statistics being addressed or dealt with, and what are your thoughts about how that fits in and makes all of this more complicated?
Yeah, you've hit on a really essential question. And one of the things that I would look towards is what we have been able to do with the veteran homeless population. Actually, we've been able to make some good inroads, and there's still a huge problem. But we do have a good healthcare system for many of these veterans, and we have been able to create more of a data system to help some of these veterans as they're popping up across different types of social service agencies. So I don't claim to have the answers, but I think that there is a really interesting model that we can be learning from as we try to think about how to expand this out to so many other populations, such as other types of homeless folks. Yeah.
And I would just say that although homeless in healthcare, we absolutely know about homeless populations. We cannot map them, but we know, we know. And this, in fact, is a big driver. It's why you see in the last year you've had, I don't know, so many health systems talk about investments in housing as actually the part of their investments. This is driven by a variety of different factors, but it's it is, in fact, I think, a good thing to have medical systems think about and step into this space. The other thing I would say, and I'm sure you're going to hear from my colleagues Courtney Lyles and Rimala Sarkar, that although we think about technology and the gaps in technology, it's technology that's also part of the solutions for our most marginalized populations. And my colleague Margot Kuchel had a nice paper a few months ago about how the importance of cell phones as being that link for homeless populations and allowing them to access services and other things like that. So I don't think, while we have to be mindful of the technology divide, I think we have to also think about the opportunities for technologies to help us reach the most marginalized populations.
Bob.
Yeah, great opening talks. Thank you both for outlining it so well. I just want to shine a brighter light on this point that Kirsten just made, and that's that we're meeting to talk about data and data science and a lot of other tools that we need to understand and use properly. But we can't forget what we're doing it for. And there's some, if we take a population problem-based challenge, then there's big problems out there that we have to address. And how do we use the technology to address it? So homelessness, yes. Immigration, yes. Gun violence, opioid epidemics. These things are all things that we're all need to keep clearly in mind. And how do we use the data to solve these problems rather than be blinded by the shiny new tools that we have as that we're going to be talking about today?
Great. Wonderful. Oh, okay, go ahead, please.
I just want to just add to the idea that someone mentioned about qualitative data being so important, because in response to talking about how to, like, what sort of forms of communication people who are homeless use, I know a lot of people who are homeless use Facebook because it's something you can use even if you your cell phone plan gets cut off and you get a new cell phone, you don't have access to the internet, but you can go to the library. So I think having the qualitative data aspect to understand how people are using these new technologies is really important so that we can actually understand what this data means.
Absolutely. Thank you. And back, yes. Sorry, Amanda. Yeah.
Hi. I'd also like to follow up a lot of the really interesting comments on how systems and communities are trying to do this sort of data sharing across sectors already. So I think I've been impressed that there's so many communities trying to solve this problem at a practitioner, public health department, health system level, that there's really starting to be quite an active sector for sharing lessons. So I think that's another potentially interesting place where research could help to help different communities in different areas learn from each other, because this is a really hard thing to do at the practitioner level to get different organizations to be willing to share their data in this way.
Yeah, I think you're absolutely right that in many ways the need is so great that you see communities trying to figure this out on their own ahead of sort of more systematic, statewide, whatever. And I think having a way for better sharing of that information, and I think that's another opportunity for partnerships with academics to figure out evaluations of those types of things. I totally agree with you. Lots of interesting models.
At the risk of being a little incendiary, which I hope is okay around here, I hope that we will spend some time, not we as in the greater we, and especially the leaders, in quantifying or somehow expressing the cost of not using data and deferring to privacy so much that we spend, wherever I go, whether here in that accredited university in South Bay, where I was, we spend so much time talking to privacy, legal risk about what to do, what not to do. They don't hear the cost of us spending month after month after month while we lose citizens, to not being able to use the data, and instead of arguing about what in the end, and I've been in data science a very long time, very arcane things, and that's a loss that I hope that we as a leadership, you as a leadership group, could lead us to talk and quantify and somehow be able to express that side of things rather than spending most of our time about the law and regulation.
Thank you. And I agree. I think that's absolutely essential to consider in the ethical trade-offs is all of the continued deaths and lack of investments that we are missing out on. Yeah.
Well, the other thing I would also point to just now in the medical sphere, how much the protection of patient privacy in HIPAA has led to an overinterpretation of privacy and really prevented the types of data sharing which are actually absolutely allowable under HIPAA. And I think, I think one is just thinking about how privacy then leads to the types of guarding that doesn't allow for the things that would be reasonable for improving health. And many have actually called for thinking about, one of the things that's challenging in this arena is that we're talking about sharing data across sectors that aren't governed by the same types of HIPAA privacy statutes. And so thinking about, well, what are the frameworks that can both allow sharing and still be protective? So, yeah.
I think we have time for one last comment or question, or two. Okay, we'll get two in. There we go.
Tomas Aragon, Health Officer of San Francisco. So there is a huge gap between academicians and public health practice. And as a public health official, the most important thing that I need help on is decision making. Fortunately, every single decision has embedded in it a causal assumption and probabilistic reasoning. The probabilistic reasoning, all this predictive analytics can help us. The causal assumption, you brought up causal inference. And what's great about causal inference is that it takes you out of the computer, takes you out of the data, and it connects you to human beings and how they see problems. Because data's dumb. Data can't tell you causality. And I actually think that causality is what we bring to the table. And it's something that you can teach. It's a language that we can teach people, the decision makers. And so I feel like that's an area of real potential for us in public health and academicians. And it also connects to performance improvement or quality improvement because root cause analysis is part of every single performance improvement activity. And so there's this nice elegant way that we can be connected with frontline practice.
Data science for decision making, another huge opportunity for us to all be investing in collectively. Yes.
Zhao from UC Irvine. I have a question about opioid epidemics because it's really, really important public health problem right now. And I know that people like me, people who are doing informatics at UC Irvine, were trying to integrate the drug monitoring program data and EHR data together so that doctors, when they prescribing drugs, they could track what, like how much quantity this patient has already has, and they don't want to overprescribe. So I was wondering if there is anything similar or even better could be done by UC Berkeley and UCSF. Thank you.
I think we were all trying to do those things. I mean, I do think this is an example. It's certainly the current public health crisis that is capturing the imagination, where that data-driven solutions actually will likely be part of the solution. I don't know that anyone has absolutely figured out. I know there are others in the room who are interested, so I hope you'll have a chance to talk about it.
Yeah. Well, thank you all. So this is a great sort of opening set of conversations to things to come.
Good morning, everyone. I'm Jen Ahern from the UC Berkeley School of Public Health, and I'm the Associate Dean for Research, was one of the folks helping organize today. It's really great to see this full room. And I often talk a lot to students and others about the great capacity we have combined, bridging from Berkeley to UCSF, and so it's wonderful to see a lot of that represented here, and I hope there'll be a lot of great conversations today. I'm just briefly going to introduce our speakers in this next session on policy, and it picks up on a lot of the themes that came up in the questions that were just asked in terms of linking these big data endeavors to decision making, and also to thinking about the bigger picture around legality and how to navigate complex privacy issues. So our first speaker is Jesse Rothstein, a professor of public policy and economics, and he very kindly made time for us today. He's been doing really exciting things with the California Policy Lab that he'll be telling you about. And following Jesse, we'll have Rita Hamad, assistant professor of family and community medicine, who's a social epidemiologist and also family physician, and she'll be talking about policy work happening on the UCSF side. So thank you, Jesse.
Thank you. Thank you very much for having me. Let me start with let me start with two apologies. The first is that I am not a population health researcher. I have never had a health variable on either the left-hand side or the right-hand side of any of the regressions in any of my papers. But I still think I have something hopefully useful to say, because I've been thinking about a lot of the issues that came up, especially in the Q&A just now, from a different perspective. And the second is that I have to run at 10 o'clock, so I am incented to keep to my time limit. So I'm going to give my talk and then run out, and I apologize that I'm not sticking around for the rest. So a couple of years ago, I started the California Policy Lab, and I started it coming out of thinking about two questions. One was, where is the kind of research that I do, this policy-relevant social science research, where is it going? And one answer to that is it's almost entirely going to administrative data. I grew up, we used the PSID, we used the CPS, we used AdHealth, you relied on the government to collect survey data. The government has been underinvesting in those data. They're much less useful than they were. Response rates have gone through the floor. And there's all this other data out there. And so increasingly, all of the work that we're doing is relying on administrative data. So that's one piece of the trend. Another is that there's increasing overlap among the different areas. I started out doing education research. I do some labor market work. Other people do health or safety net. But increasingly, the questions we're interested in are about the overlap between them. It's about how a safety net program affects child development, or about how access to good schools leads to better family structures. There's a range of different questions that we might be interested in, and you can't stick them in these silos. So what does that mean? That means not only do we need administrative data, but we need administrative data that's coming from lots of different agencies. We can't just rely on the one variable that the agency we're working with owns. We need to be able to map it to data coming from other sources as well. But administrative data is hard to work with for academics. It's, by definition, it's data that was collected not for us to use. Nobody spent time when they were developing the data set thinking, what's the right measure that we want to use in our analyses? Because that's not what it's there for. So we have proxies. We don't have direct measures of what we're interested in. It's owned by agencies that have jobs to do. They have programs to run and things that they need to get done that have only tenuous connections to the kind of work we do. And so if we approach these data as saying, how do I get the data? How do we get them to share the data with us? And then I'm going to do some work, and then I'm going to tell them about the policy relevance of my work. That's not going to work that well. So we need to figure out ways of working more closely with the agencies that own the data and making sure that the work we're doing is built from the beginning to meet their needs. The data are not cleaned or pre-processed, so there's a lot of work that has to be done up front before we can use it for the kinds of things we're doing. You'll often notice when you use an administrative data set that there's a variable that's in there that isn't really core to the agency's operational goals, and nobody's ever looked at it, and it's a mess. It's not like we have the Bureau of Labor Statistics or the Census Bureau that's already doing a lot of the pre-processing for us. And another piece that really motivated me when I started the Policy Lab is that these data are a new thing for universities. They don't know how to deal with them. The lawyers don't know how to deal with them. The IT departments don't know how to deal with them. The IRBs don't know how to deal with them. There are new issues of all sorts that come up. And so we need to figure out ways to make universities work better with these data. And we need to make sure that those projects are collaborations between researchers and agencies, not just one-sided, we do our study and then give you the results. That's not going to work. Another takeaway from this is we need to think about building data systems. It's not just a question of we get a computer and we download the clean data. It's not just a question of sending out requests to all the agencies whose data we want and asking them to share it with us. We need to put effort into building the systems that will make the data useful for us. We're doing a lot of it on our own. So what did I create with a couple of colleagues? We created something called the California Policy Lab, which is an effort to really foster collaborations between researchers in the university and government agencies to pursue joint projects that meet the agency's needs. The agencies are part of developing the research agenda, and then the researchers come in and bring in the expertise about how you do research. We bring those together to generate projects. They rely on administrative data. They're collaborative from the very beginning to the very end. We develop the questions together, we do the research, and then we develop the outreach strategy and the rollout strategy together to make sure that the results are actually influential on policy. We've done a lot of work on developing legal and data infrastructure to streamline the setup of the projects. I know there was no part of my PhD where I learned how to negotiate a data sharing agreement, and I am not good at it, and it's not a good use of my time to be trying to make that up from the start. So what we're trying to do is create infrastructure that makes a lot of that easier. And that both means developing the agreements, working with the agencies to figure out what they need, and also educating the university on what it needs to be doing. We've had a lot of work trying to explain to the agencies that we're working with that our data sharing agreement with the food stamp program, a first order concern is not who owns the patents that result from this work. That's their first order concern, it's just not relevant to the work we're doing. And then the policy impact has to be part of it throughout the process. The explicit goal of the project is to improve policy, to improve people's lives through these partnerships. And we're from the beginning, we've conceived of this as a cross-sectoral effort. That if you're working in education, you can't ignore employment outcomes. If you're working on criminal justice, you can't ignore the interactions with the safety net. There's a lot of overlap among the areas we're working in. So we conceived of 5 areas that covered a lot of the ground that those of us who started this worked in, and they cover a lot of social policy. There's obviously a missing piece in those 5, which is health. And so one of the things we're looking to do over the next couple of years is try to expand to bring in health researchers who can bring us the expertise. We really didn't have anything to offer to health agencies when we started this. We could offer criminal justice expertise, we could offer safety net expertise, but we didn't have health services or population health expertise to offer. So we want to expand to do that. And we want to figure out ways to do a better job of reaching the agencies that have responsibilities in that space. I'm not going to spend a lot of time talking about the model. I'll just say that I never spend any time negotiating data sharing agreements anymore. I never spend time talking to the lawyers. We have a staff that does this, and once these agreements are in place, which can often take 9 months, 2 years, somewhere in there, but once they're in place, we can start new projects often in a week. We don't need to go back to the lawyers every time we want to add a new project, which is one of the really big values of this. Okay, let me just talk a little bit about how to think about applying this to public health. So everybody, when they start thinking about administrative data in health, the first question they ask is, what about HIPAA? And HIPAA compliance is difficult. There's no question. There are extra rules in HIPAA that are not in other areas, which is one of the reasons why we left out health data when we started the project. But HIPAA compliance is not impossible. We've got a server that gets us there, and we've got processes in place. The problem that we're facing is we don't have the subject matter expertise. That we don't know enough about health care and health services to be able to do a good job in this area. We think that our infrastructure is valuable and is kind of the way that the university should be thinking about doing this, about having specialized data protection lawyers, specialized IT, everything else that help us, that help you do this work. And what we're looking to do is bring in more expertise and broaden our network over the next couple of years. And so if you're interested in this, I think what we're looking for in doing this is we really need to maintain the focus that we're interested in meeting the agency's research needs and in having policy impact. This is not, I'm going to come up with my paper and then tell you why you should change your policy. This is, I'm going to work with you to figure out how our work can meet your needs. You've got to be interested in working with the policymakers. That means lots of work that might not be publishable, or lots of work explaining your results to people or why the strategy makes sense to people who haven't taken 3 years of your causal inference classes. But that is important and it should be done. So the idea of our projects is we produce not just journal articles, but also outputs that are more accessible to policymakers. And we work with them to figure out what that implies for their work. The projects are often iterative with multiple steps where we keep developing on results and going to the next step. And thus far, in many cases, it hasn't been clear how do we publish that. But that's okay, that's not the point. Again, the value of this, the researchers, I think, is it takes off the table a lot of the things that you have to spend a lot of time doing that are often prohibitive, that really aren't your expertise, and tries to allow the researchers to focus on research. So I will stop there. I'd be happy to talk to others about this. My email address is my last name at berkeley.edu if anybody wants to reach out. I am, again, going to have to run in just a couple of minutes. Thank you.
Over there. Thank you so much, Jesse, for a wonderful talk. I had a question about just the practical aspect of the data. So it sounds like you have servers for HIPAA compliance and things like that, but the agency data itself that you guys take in, you are developing your own repositories and all of those kinds of things here. And do you envision health as following that model, or a model of maybe some of the data can't be transferred, but you could still work in a similar way to figure out what the data sharing could look like in that kind of capacity?
We've been flexible as we approached agencies. Different agencies have different abilities to do this and different needs. So in some cases, we bring in the data and maintain it. In other cases, we have embedded researchers at agencies to work with their data. There are limits on how much you can accomplish with that. A common experience we have is we're working with two agencies that want to link their data together, and each of them tells us, okay, great, get us the identified data from the other one and bring it in-house here, and we'll do it. And that obviously, somebody has to be willing to give up identifiers for this to work. We figured out ways around that in some cases, but it's challenging. I think in the long run, we need repositories that keep the data and keep it there for a long time. So much of the work of working with administrative data is preparing it to be able to use. And if you throw that out at the end of your project, then you're starting from scratch. I am not committed to it being on our servers. There are some advantages to it being a third party, and one advantage of being at the UC is we're part of government, and so there are laws that say you can only share it with other agencies. We're another agency. But it would be great if the state developed the capacity. We're working with some state agencies. I know CHHS is working a lot to build their own repository, and we've been helping advise them about how to make sure that that's useful. And we're open to however we can get the data made useful for the agencies.
Hi, Kristen Markey, Center for Health Equity at UCSF. I had a couple of comments, I guess. One is that I think with going into health, you actually, with the domains you already have, a lot of work can be done. A lot of research already has shown how those are related to health. So you can go, you could be moving forward with analyses related to health without even adding health data to what you already have. And the second point a question I have for you is thinking along the lines of what Claire said earlier, where the community fits into all of this as well, and how they come into, say, policy advocacy or decisions about where you move forward with your policy planning.
Right. So absolutely many of our projects that we're already going or have health relevance, and to the extent that we don't need health expertise to study that, we're interested in doing it already, and we're interested in doing the other part also. We just don't have the expertise yet to do that. Community engagement is a super important part in the long run. In the short run, we kind of started with projects where there were already initiatives underway, and we just relied on the agency that was already doing their community engagement. It's not enormously controversial that it would be better if more people took up Cal grants than if fewer people took them up, although the Department of Finance sometimes objects to that. But as we work in more sensitive areas, it's going to be incredibly important, and we're working on developing that. It's one of the challenges of working across areas is we can't engage all the communities on all of the projects, and so we really need to rely a lot on the research leads on projects to play a role in that. But I think it's enormously important. Is there one more? Am I done? Okay, great. Thank you.
All right, that's showing up for you guys. Great. So thanks to everyone in here and out there in the other rooms for joining us today. My name is Rita Hamad. I'm at UCSF, and I'm going to be speaking to you guys today on data science to study the health effects of social policies. And I'm excited to get this research agenda moving forward. So many of you are probably familiar with this figure or something like it, which shows the determinants of population health according to the social ecological model. And these range from, I think I have a pointer here. Let's see if this works. From social and economic policies at the most upstream level down to individual risk factors and everything in between. And the idea is, briefly, that intervening on social and economic policies upstream has the potential to influence health and inequities at the population level. So what's our role at academic institutions in informing policymaking? So both UCSF and Berkeley have something in their mission statements to the effect that they are interested in improving population health and health equity. And this requires that policymakers implement effective policies. In an ideal world where we have evidence-based policymaking, which is a pipe dream most days at some levels, there needs to be scientific evidence on what policies work best and for whom. So one method to generate such evidence is to evaluate existing policies, and another is to conduct experimental work to test interventions that inform the mechanisms that link these upstream factors in health, which can then be used to inform policymaking. And as academic institutions, we're limited in our ability to work with policymakers, although it sounds like Jesse's work at the California Policy Lab is helping to move that forward, but we can use our expertise in the realms of discovery and evidence production to help move this research agenda forward. So what are the characteristics of an effective policy research agenda? And I envision the following key pillars to maximize our impact. One is that we need to be asking relevant questions that are informative to policymakers and communities. We need to be generating evidence when it's most needed, that's timely. We need to be using rigorous methods, of course. And we need to examine how policies affect different groups differently to make sure that inequities are being addressed. And at UCSF, as you've heard, we like to call this precision public health, although I realize some people don't like that word. But that's my use of precision public health. So the reason that I'm here today is to describe the challenges in this field and a vision for how to address them. And to that end, I'm going to talk about three main issues. The first is data, of course, because this is a data science colloquium. And the second challenge is methods, and in particular, as we've heard, it's difficult to study policies rigorously when randomized controlled trials are not generally feasible. And the third is data, because I felt like I had to list three things, and this is a data science colloquium, but data. So in terms of data challenges, I see four main domains where we have potential barriers. And the first is that data need to be relevant. For example, we need data that include the health characteristics we're interested in, the geographies that we're interested in. The second is that they need to be timely. We need to be able to respond quickly for the sake of these communities that are being impacted by these ongoing policies. It goes without saying that they need to be high quality. And finally, we need population level data that capture the people who are affected. And it's important to note that a given data set might meet these criteria for a given research question, but not another research question, so we need to think on a case-by-case basis for each of these data sets. And I'm going to walk through an example of how these criteria apply to a specific research question, and then discuss one example of a potential solution. So this is a figure about SNAP participation over the last 10 or 15 years. And it was about 10 years ago that the Great Recession hit, and participation in SNAP or food stamps roughly doubled. And the question is, who were these new recipients? Are these higher income people that are newly eligible because they lost their jobs during the recession? Or is this people who were previously eligible and they had fallen through the cracks and now are getting enrolled? And the reason this is interesting, potentially for practitioners, is that we may need to provide different types of services if this is a fundamentally different population than existing recipients. So you can think about how you would answer this question and what data sources are out there. So let's think about using clinical data like electronic health records or claims data from UC or Medi-Cal. So are these relevant? They have very rich health data, but essentially no data on SNAP participation or, for the most part, socioeconomic status in general. Are they timely? You might be able to get UC clinical data within a few months of it being collected. For those who've tried getting Medi-Cal data, it's almost impossible, and it may be years if you get the data, if you get it at all. Are they high quality? I'm not going to put maybe because I'm not going to wade into the debate about whether clinical data are good at inferring health status. And are they population level? UC data for the most part are not because they overrepresent tertiary or quaternary care centers, and Medi-Cal data are not population level, although for this particular question that's okay because they represent the population we're interested in. So let's think about something like the Panel Study of Income Dynamics, or PSID. For those who aren't familiar with it, this is a cohort study that's been following the same 75,000 people and their families since the 60s. Are these data relevant? They do include rich data on sociodemographics and SNAP participation, but very few health data. They're timely in that PSID tends to release data within a year of collection. If you're studying an infectious disease epidemic, that's not fast enough, but for our research question, that's okay. Are they high quality? They're self-reported, so I put maybe again. And they are population level because PSID is intended to be nationally representative. So last data set, this is the USDA's National Household Food Acquisition and Purchases Survey, or Food Apps. This was a cross-sectional study that interviewed 5,000 households in 2012 and 2013. It's certainly relevant in terms of the excruciating detail on nutrition outcomes, although they didn't ask how long somebody had been on SNAP. It's timely, it covers our time period of interest, it's high quality data, and the data, again, are intended to be representative at the population level. So what do we do in the case that we have numerous data sets, none of which allows us to answer our research question? And I think what we're increasingly going to need to do is creative data linkages to answer these types of questions. In this case, what we did was we ended up using PSID and creating a probabilistic machine learning algorithm to predict whether somebody was a new or existing SNAP recipient. And then we applied this algorithm in food apps, and each person got a probability of whether they were a new or existing recipient, and then we deeply characterized these two groups. For those in the know, this is not a new technique. It's rather a novel application of old tools. So social scientists might recognize this as two-sample instrumental variables. Genetic epidemiologists may see the parallels with Mendelian randomization. And the idea is that we could potentially do more of these linkages in data sets that are missing the information that we need. And then in some cases, the problem that we have is that samples simply aren't given enough in a given study. And sadly, we're not in Scandinavia where we have identified data on everybody for everything you would want to know about. And so I think what we're going to be seeing an increasing reliance on is meta-analyses, again, learning from genetic epidemiology, where meta-analyzing GWASs is increasingly common to get sample sizes in the millions. So let me move on to methodological challenges, because data science is not just about data. And again, our primary challenge here is that RCTs are hard to come by in the realm of policy analysis. And as with data, we need methods that are relevant to our questions. For example, causal inference versus prediction. We need, of course, high-quality methods, because presumably these are going to be used to inform policymaking to affect millions of people. And again, we need methods that are going to enable us to make inferences at the population level and for highly affected subgroups. And to address these challenges, I think we're going to increasingly need to get creative about identifying natural experiments, which are a source of variation that allows us to look at more causal effects on population health. And as with data, often one single type of method or natural experiment is not going to provide enough insight. And so we're going to need to examine policies from multiple angles and to get enough information to triangulate or converge on the truth. And again, I'm going to walk through a particular example with one policy that I know more about to provide a concrete example. So in this case, let's say we're interested in how income supplementation affects health and are therefore going to look at the largest poverty alleviation policy in the US, which is the Earned Income Tax Credit. For those who aren't familiar with it, the EITC provides tax refunds that increase as your income increases up to a certain plateau, and then they're phased out. And you can think about how to analyze this policy. One example is you could compare people who are just above and below the cutoff and use something called a regression kink design, where you'd have a control group of people who are roughly similar, except they make maybe a few $100s more. You might not like this natural experiment because you think there's something fundamentally different about these people, so they're not a great control group. Thankfully, the EITC has another form of variation we could use. So this is actually the maximum refund size for 3 kids, and families with 1 kid get less, and 2 kids is somewhere in the middle. So you could compare health outcomes among these groups and leverage that source of variation in income. Again, you could say, those families are very different from each other. I don't want to make that comparison. The EITC has another source of variation. So in this case, the refund size on average has varied a lot over time, and in particular, there was a large increase in the refund size during the 90s under Clinton, and so you could leverage that source of variation. Again, you might think, oh, there's other things that have happened over time. I don't like that natural experiment. There's also variation by state, and the point is that there's, for any given policy, there are at least a couple of sources of variation that create the sort of natural experiment that we can use to examine its effects on any number of health outcomes. So basically, for those in the medical and public health domains, this is a call for interdisciplinary collaborations with our social scientist friends, many of whom are here at Berkeley, who know the ins and outs of these policies and can inform the optimal quasi-experimental design and have more expertise in the more social science data sets like PSID. And for social scientists, collaboration with health researchers, as we've heard, can lead to richer studies that examine health outcomes beyond the usual economic studies of mortality and fertility. And for those intimidated by the methods and the different language, these hurdles are surmountable, and there are glossaries out there. And I always like to say social epidemiology and health economics are 2 sides of the same coin, and we often ask the same questions worded differently. And thank you for your attention.
Thank you. This was a fantastic talk. I did want to, I guess it's as much a comment as a question. I think one of the things that keeps coming up again and again and again is that if a agency or individual has a large hoard of valuable data, all the incentives seem to be to hide, hoard, or monetize it. And I think to the point about starting to balance the cost of not making that data available, and I wondered if you'd had any luck with, say, Medicaid. Like, has there been anybody that you're aware of who's been able to get those valuable data for health research?
Yeah, so for Medicaid in particular, that's been a personal tragedy because I would love to be able to use that data set myself. We have, Andy Beinman at UCSF at the Philip R. Lee Institute for Health Policies, who is one of the very few people I know, and it's because he has sort of personal friendships with people in the Medi-Cal office. What I've found is that California is required to pass those data on to the federal government. So if you wait a few years, you can request them from the federal government itself through CMS, through established pathways that, you'll get the data eventually. It's just going to be a little bit longer. But I think that's like getting data from our state agencies, I think is a huge hurdle for us, particularly at UC and in California, just because there seem to be so many more barriers and obstacles than other forms of data. And now I'm hearing Jesse speak and hopefully having some agencies in the room and more collaborations with them, I hope that it can be more of a collaborative relationship where the mutually beneficial aspects can help open up those data resources, because our goal is fundamentally to help them do their job better given their limited bandwidth and their limited funding. So Medi-Cal is a particular challenge.
So you may have a moment in time, Rita. There's a new director for the Department of Healthcare Services who's a pediatrician who came up out of the data systems at Stanford, a guy named Mark Ghaly, who just came up from Los Angeles. So I think that there may be a moment in time here where not everybody at once, but sort of having a concerted effort to strike for better access to data. And I'm reminded that the vital statistics data for California get released in the old days, there was a pre-release before it went to the feds, when it went to the National Death Index. So there is a precedent for an early release before it gets federalized and then kind of eventually comes back 3 years later.
Your EITC data, imagine being able to link it to their medical records. That would be a very ideal situation. So grasping at straws over here, I'm wondering whether there's any hope for foreign data sources where they have the 360 view of so many citizens. Hope and value is like I said, grasping at straws, because you could get some data that might be partly applicable at least. Is there anything there?
You mean being able to get data sources from other countries?
Right. Where they have a full-on view of their citizens.
Yeah. I mean, I think that's definitely possible. I have a couple of collaborations with Scandinavian colleagues where they also have lots of data. They're very aware that they don't have the bandwidth and have been very open to collaborating, researchers in Denmark and Sweden. They have sort of their own data protections with their own governments about not letting the data get out too far, but there's definitely possibilities there. I focus more on domestic sources here, but for those interested in global health, I think at least in Scandinavia, there's that possibility, and maybe later we can talk about those who have more expertise in low and middle income countries. All right, thanks.
All right, so coming up next, we have Mahasa Mujahid and Courtney Lyles speaking together, showing how collaborative we can really be across the Bay. Mahasan's a social epidemiologist, cardiovascular disease specialist, and Courtney Lyles, associate professor of medicine, and we will be learning about their work using EHR data and connecting them with place-based information. So thank you both.
Good morning, everyone. It's very exciting to be here. I really thoroughly enjoyed the morning session. I was like taking notes and sort of all the questions. I was like, yes, that, and that, and that. So I think, it's a really exciting time to be thinking about this. And I just want to sort of underscore the time that we're in right now, where we really have a strong health equity agenda that we're launching in terms of really improving population health and improving health in marginalized populations and making sure that everyone sort of is able to attain the highest level of health. And social determinants are really key to that. So I'm going to talk a little bit about some of our work to bring more social determinants into the UCSF health system. And before I get into that, I just want to talk about a brief aside on a program that sort of just happened actually a couple of weeks ago that was held at the California Endowment. And it was a health equity sort of bringing together people who do health equity in the state. So all of the schools and programs in public health were brought together, including deans and chairs and people who are engaged in research around health equity. And as I mentioned, it was held at the California Endowment, and we were really charged with sort of trying to figure out how we're going to be the leaders in the state of California to move the needle around health equity in the next 10 years. And in a lot of ways, we're the leaders in relation to so many different sort of initiatives and agendas. And one of the things that we wanted to emphasize in that convening was that we have access to so much data. And so how can we sort of have better data sharing efforts, sort of do it better, ask better questions, force ourselves and challenge ourselves to think about really moving the needle, and that as California, we are the ones that can actually do it. And I think a lot of what we're talking about today is going to be instrumental in helping us move the needle in terms of health equity. So I mentioned that we sort of are working around thinking about health equity and electronic health records systems, how we can sort of include more social factors. And there was a committee that was commissioned by the Institute of Medicine, now National Academy of Sciences, Engineering and Medicine, to really think about those domains that we should include in electronic health records, the social domains, the behavioral domains, sort of what I'm going to focus on is sort of the residential addresses, which is actually sort of really key to really understanding sort of place-based context and what patients are bringing into the clinic. But as you can see, there were a number of other recommendations that were made not only by the IOM, but other sort of leading organizations to really bring more individual level social factors into EHRs. So if we just think about sort of some motivation around what is this all for, because it's a labor of love in terms of the resources that you need to bring more information into EHRs that are very difficult to maintain. Every time there's a change in ICD-9 codes, there has to be a major overhaul in sort of an EHR system. So why now are we adding other things that people are responsible for entering data and sort of the uptake and maintenance of that information? And so we thought a lot about sort of the utility of this, and as we're doing this work, we're always thinking about how we can improve sort of thinking about the utility across a number of levels. And so I'm going to just emphasize a couple of examples to think about the utility of bringing in sort of neighborhood level data into electronic health records, focusing in on sort of the potential around risk stratification, around targeting and targeting preventive interventions, and then also the use in public health research. So this is an example of some work that was done to really look at sort of how to identify high-risk areas. This is data out of Minnesota, and what they did was they used sort of electronic health record data and zip code information to identify sort of geographic areas that had high levels of uncontrolled diabetes or sort of the least effective control of diabetes. And so the idea is that these were areas that they could then identify for targeted intervention and outreach, and to think about sort of what are the community level assets or needs to actually improve the ability to control diabetes in these areas. So this is one example of the utility of being able to really understand your patient population, understand where high-risk individuals may live in that population, and thinking about strategies that can be effective in those spaces. This is another example of looking at sort of the utility in relation to public health research. This is an example of electronic health record systems across, sort of really thinking about how we can integrate these systems. And there are a lot of other EHR systems that are starting to do things like Geocode. I was involved in a diabetes project at Kaiser Permanente, where we sort of took advantage of the fact that Kaiser has been geocoding sort of their electronic health records for the past decade or so. And this is Kaiser in Division of Research in Northern California. And so we've been able to do a lot of work around sort of looking at diabetes in that population and understanding the sort of what does diabetes management look at when people come from marginalized communities with few resources and needs, high crime, sort of and other community-based issues. And then also in thinking about public health research, it's an opportunity to sort of use EHR data to identify smaller populations by either targeting high-risk areas, targeting certain groups that are underrepresented in data sources, or targeting rare outcomes and being able to sort of develop those areas based on having more information in EHR systems. This is an example out of Johns Hopkins Children's Center, where they actually conducted a randomized controlled trial that looked at whether they could see improvement in obesity outcomes when children were and families had additional screening around social determinants, when they also sort of connected children and families to resources in their communities around active living, around healthy eating, and that the group that was randomized to receive this additional sort of screening on social determinants of health had better outcomes in terms of obesity than those that were randomized to not receive that that additional screening. And then finally, this is some data to also talk about sort of this idea around sort of what can be done when we think about sort of targeting specific areas using electronic health record data on social determinants. So this is an example of some research that's looking at sort of a cardiovascular health score and really understanding sort of what that looks like in relation to expenditures of fruits and vegetables. And this is some data that was done by Roth and colleagues. And so again, you can sort of really understand how you can sort of focus in on high-risk areas by having this additional level geocoded data in EHR systems. So I'm now going to talk about the work that we started on a couple of years ago at UCSF to geocode the electronic health record system. And so it started off with a data dump of about 5.9 million records. These records were extracted from the UCSF health system, and it was between this period of 2010 and 2017, and they were de-identified, so that when we were geocoding, we were just working with the address level data, and then we've uploaded that data back into the EHR system. And so the data was imported into ArcGIS, and then we used 2016 business analyst data, street segment data, to geocode to the Latin long based on having information on the house number or street number, street name, and the zip code for all of the 5.9 million records. And as you can imagine, my thoughts going into this was, oh my goodness, this is going to be a nightmare. Data quality is always an issue. But then I thought, this is for billing purposes. And so at the very least, there's going to be some expectation that people need to have accurate information on their patients for billing purposes. And I think what we found was representative of that yes, it was messy, but much better quality than what you could expect for some other fields in an EHR system. So what we wanted to do was to geocode as much of the data as possible, and so we geocoded down to different levels of granularity with the idea of trying to geocode to the lat long based on the exact address for as many patients as possible, and we were able to do that for 75% of the 5.9 million records, and so we were very proud of that. For an additional 15% of the records, we geocoded to the midpoint of the street, which is also giving us a high level of granularity. And then for less than 10% of the population, we did have to geocode to the zip code level. But again, we have over 90% of our data that was able to be geocoded at a much finer level of granularity than the zip code. And then what we did was link the information to the American Community Survey using 2012 to 2016 5-year estimates, and then we assigned other geospatial measures based on using census tract data. And then we have the lat long data, so we can do other kinds of geocoding to other aggregate units, but the census tract was the way that we could ensure issues around confidentiality, and also we know there's a lot of work showing that census tracts can be predictive in relation to a lot of outcomes based on neighborhood physical and social context of those census tracts. So this is an example of why we really worked hard to geocode down to the lat long. This is a hypothetical patient in San Francisco, and you can see here information on what the median household income would be assigned. The median household income is the one indicator that was recommended in the IOM report that I mentioned earlier. And you can see here that based on this hypothetical individual, the block group has a median household income of $116,000. The census tract also $116,000, but the zip code, surprisingly, $29,000. And that's because you can see here that this individual is represented in this zip code, which includes, over 15 census tracts, a even larger number of census block groups, and they're also right on the borderline of this other very large zip code. And so having information where we can actually get down to the lat long and then think about the aggregate level data that we want to use is really important so that we don't have this modifiable area problem. So of the 5.9 million records, we had about 75% of our patients that only had one record or one address on file. There were close to 3 million unique patient records, and so for the other 25% of our patients, they had multiple records, and so the minimum number of counters was 1, and then the maximum was 232. So you can see some of the high users that exist in the UCSF health system, and so there's a lot of opportunities to think about this distribution and where we focus in on this distribution in terms of next steps. This shows you the coverage across the state. We also had coverage in the outside of the United States. About 4% of the records were coming from outside of the United States, but 96% coming within the United States. And then of that, about 48% of them were within San Francisco County, which would be the primary target and outreach for the UCSF health system. And so then the next stages are sort of thinking about and what we've begun to do, and I'm going to turn it over to my colleague Courtney now to talk about the multiple ongoing projects from creating this data resource. So some of the examples include looking at neighborhood level socioeconomic status in relation to sort of diabetic complications and uncontrolled diabetes. We're also doing some work around hypertension right now to look at uncontrolled hypertension among patients within UCSF. And sort of looking at that overall and those who are receiving usual care. And then we're also doing some work to actually look at pharmacy deserts within San Francisco and thinking about sort of hypertension control in relation to having access to high quality pharmacies. So now I'm going to turn it over to Courtney.
Thanks so much, Mahasen. So this great project, I hope you can see the collaborative nature from the beginning, really couldn't have happened without Mahasen and her team's wonderful support. And the number of research projects that she mentioned are also collaborative in the sense that each investigator is coming up with lots of different questions. This data set obviously is very rich and trying to think through how we can work together on research questions. And I thought I would also spend time, though, thinking a little bit broader. It overlaps with the research questions, but it also, this project has really emerged into something else when thinking through both internal audiences at UCSF Health, like our healthcare leadership team, as well as other relationships and external partners where we want to expand the potential of this data to get other healthcare systems to participate and contribute data. So I thought I'd touch a little bit on that. And because we had such great collaborative, we also sought internal funding through the Executive Vice Chancellor at UCSF to launch something that we're calling the UCSF Population Health Initiative. And one arm of that initiative that Kirsten and I lead together is on place and health. So with this data set that we've created, we've thought through really a couple different objectives. The first that Mahasen alluded to is, of course, we want to make all of those geotags available within the electronic health record itself. So we already have completed that with the help of Mark Pletcher and others. We've re-uploaded those geotags that Mahasen created back up into our EHR. It's in the EHR system, but it's available in case people want to, either for operations or for get IRB approval, to go in and download those without having to geocode the data themselves. Sorry, so that's the first. The second is that is related to what I was just alluding to, which is how can we create internal clinical data set to match all of those geotags, right? 6 million records. We're not going to pull all of the AHR data for all 6 million of those records. That's a ridiculous amount of data. Every researcher has specific variables that they're interested in looking at, but how can we think through high priority conditions and generate data sets with good clinical data that we could go deeper on and think through longitudinal questions and other things like that. So we've spent some time thinking through what kind of clinical cohorts of data do we want to create to match to these indicators. And when I say that, I want to think both about research questions, but also about clinical operations. What are the things that the healthcare system is already prioritizing, and how can we leverage these data to show that the value back to the health system that also advance science at the same time? And then lastly, how can we think about relationships with local government, other healthcare systems in the Bay Area, and also the other UCs to expand the impact of this work? So that's really our mission with the Population Health Data Initiative. And thinking about that internal focus first, these are the sort of the 5 conditions that we've chosen to focus on in our first year. And we have thought through both chronic conditions across the lifespan, like asthma, diabetes, and hypertension. And then we've also thought through high priority conditions for the system and also for research in general, thinking about aging as a broad characteristics. Where do our aging patients live? How do they access the healthcare system? And then, of course, opioid use and misuse. And while we have data across the whole state, like Mahasen alluded to, we at first have decided to look at locally within the San Francisco Bay region and also within San Francisco County, just as a starting place to sort of get our handle on the data and then to come up with approaches that we can then expand larger. So I thought I would just show a few examples of the types of things we've done and then hopefully have some time for questions. So this is an idea of thinking, again, just about San Francisco, where about 50% of the patients that Mahasen mentioned were geotagged to. This is a base layer map of something that relates to neighborhood socioeconomic status. So this is something that's created by the UCSF Dream Lab with some of our partners, Scarlett Gomez and others, who have taken census tract level information, about 5 different census level variables, and creating a composite measure of socioeconomic status, publicly available measure. So income, education, occupation, all the traditional SES indicators, and created quintiles of socioeconomic status. And then they've made it relative to the state of California. So it's not a national index, it's a California relative index, and San Francisco, of course, still skews higher, but at least it's standardized to the state of California. And to show by census tract what socioeconomic status looks like. And then we took our diabetes data and we thought through not just first where our diabetes patients live, but thinking through control of diabetes, so their control of a recent hemoglobin A1C test, and then even one step beyond that, clusters of patients with uncontrolled diabetes. So try to overlay the clusters, so this is people who live within 400 to 500 meters of one another, how closely they live together based on their control of their diabetes status. To show through, maybe there's some traditional neighborhoods in here where we're already thinking through the interventional piece or some of the other utility pieces that Mahasan mentioned earlier, but also maybe some other neighborhoods that haven't been on the radar for thinking through a local population health management strategy. So that's one sort of example to give you a flavor of what we've been working on. And then the second example I wanted to show was that we don't just sit on one clinical system. So my primary appointment at UCSF is actually at Zuckerberg San Francisco General Hospital. That's an entirely separate clinical health system with an entirely separate EHR. And so what we've decided to embark upon is creating similar cohorts of patients for those same high priority conditions in the second health system. So we started with diabetes, hypertension, and opioid use at ZSFG and in the surrounding clinics that are part of the San Francisco Health Network. And what we've done is we've used Mahasan's protocol and her approach to apply the same geocoding strategy to new data sets. And so we're still in the process of collecting all of the data, but just to give you a sense that we could maybe harness and link two systems in at least things that we have control over. So to give you an example of what that looks like, this is a second condition. This would be hypertension. And this is the same base layer map, just has different colors of neighborhood socioeconomic status. But now we're looking at both systems' combined data of hypertension control with larger circles and darker circles representing bigger, more uncontrolled groups of patients at the census tract level overlaid on that neighborhood socioeconomic status map. So again, similar to the diabetes clustering that I showed, just to give a visual representation in a local context, but harnessing a much larger sample size of patients with uncontrolled hypertension. And then the second thing that we've been thinking through is, of course, neighborhood socioeconomic status is not the only variable that you can think about. So we've done some similar analyses thinking through different base layer maps. So the top layer here is still exactly the same, patients with hypertension and control of hypertension, but now the base layer map is thinking through green space and the access to green space and in the local environment, again, at the census tract level. And in a related manner, street connectivity, which is related to walkability, so the idea of physical activity in relationship to hypertension control. So thinking through, from a visualization standpoint, high priority questions, leveraging the data that we already have access to, and then trying to think through harnessing the clinical value of the data, but linking that to at least key census tract level variables that are out there in the public space, and ready to do more, essentially. So you might say, well, that's not the entire population. We're very well aware that two systems does not represent the entire population, even in one city and county like San Francisco. So we've been fortunate enough to partner with the Department of Public Health, like Kirsten alluded to earlier, as a part of their Partnership for Healthy Cities initiative funded by the Bloomberg Philanthropies. And their initiative really nicely overlapped with our goals of creating chronic disease surveillance and data sharing for thinking through what does it look like to have obesity, hypertension, and diabetes in the city and county of San Francisco. So we've been able to partner with them, share data with them from our project, and then they've been going out and trying to think through how to get the Dignity and the Sutters and the Kaisers and other people to contribute the same kinds of data and have them be an honest broker of data and a repository of data for the future. And this is sort of in alignment with World Cities Day and other things that San Francisco is one of those 200 and so cities that Kirsten showed earlier working on this kind of initiative. And then lastly, of course, that's a regional approach. So we talked a little bit earlier about the statewide approaches. What about all of the other UCs and all the other UC data? So of course, we'd have more leverage across the UC Medical Center. We've been collaborating with UCLA to have a similar geocoding approach in the UCLA Medical Center. And then, of course, we are working on, and hopefully with the tool Butte's partnership, thinking through a UC-wide, UCOP approach to geocoding all EHR content as it's delivered to the central repository that hopefully in the future will have a vision for all of us to be able to access that data. So in summary, I just wanted to close with, I hope I can convince you that there are many different utility and value propositions from the ones Mahasan presented and some of the graphs and things that we've presented for using EHR data. No data set is perfect, but you have to start somewhere. And that collaborations, working with people with expertise, can be extremely fruitful both for research questions, but also for operational goals. And I think we should be thinking about that as we move forward. Aligning this work with health system leadership has been an important strategy of ours, not just because of the visibility that it can create on data science approaches, but also because of they've already been doing tons of work in this space, right? They're not publishing it like we might be doing, but they've already been working on this. They've already been thinking about geotagging their data, and they're ready to partner with us and think through what the next steps would be. And then obviously, getting other healthcare systems to participate and share their data is not an easy task, but this new model of value-based care, I think, creates an incentive for people to think about population health a little differently, and I think we're starting to see conversations change, and hopefully it will continue in the future. So we wanted to acknowledge many, many people have been a part of this project, and thanks for listening. So yeah, we'll take a couple questions. Oops, sorry.
Hi, I'm Kyla Wynn at UCSF. Thanks for that great presentation. A lot of the conversations have focused around how a lot of these data sources aren't representative and kind of what a challenge that is. And I was just wondering if any of you have thought about like a raking kind of sample weighting technique that you don't necessarily need to know much about how the population was initially sampled, but you can do some, adjustments later to kind of maybe see whether things look really different, when you rake or don't rake, or, just one of those options just to, it seems like sometimes we're just kind of saying, oh, can't use that one, it's not representative, but maybe there's so much data there, maybe we can still do something with it.
So I'll just start off by saying that, it is true that, sort of no one health system is going to be representative. I think, particularly coming from a population health perspective and as, social epidemiologist, I'm always thinking about sort of prevention and sort of before people get to, sort of any kind of hospital system, et cetera. But the reality is that, we're losing that battle. And if you think about that report that came out in 2017 from RAND, 60% of Americans are living with one chronic condition, something like 30% are living with 3 or more chronic conditions, and then another 12% or something are living with 5 or more chronic conditions. And so we really are going to have to sort of make healthcare available for all and maintain that, because we need people managing those chronic conditions as we're continuing to work on prevention. We're losing the battle. And so these data sets are going to become more and more representative if we do it right in terms of making healthcare available for all. But if we do it right in terms of the prevention, then maybe, we will continue to sort of have an issue around representation. In terms of weighting, yes, there's obviously strategies for doing that. And then we also have plans to link this with other kinds of initiatives that are going on. 500 cities, as an example, can be linked to sort of these data sets where some of the cities in California are represented sort of in our database. And those data aren't perfect either, but again, it's about sort of leveraging multiple data sources and all of the sort of strengths and limitations of those data sources.
Hi, great presentation. I've got a question, but also some for the audience. I'm not sure how many people in the room might be aware that all of the Alameda County facilities are going to be going on the platform that you had up on your slide, OCHN, which is one of the best, collectors of data sets for social determinants in the underserved population. So, down the road a little bit, we'll have all of Alameda County basically with that kind of data being collected. My question to you is, are you working with OCHN today? And if not, would you like to? Because they have basically 5 million Medicaid patients in their database representing 47 states across the country.
Yeah, we're not currently working with OCHN. I've long read all their papers and been involved in many of their talks. I think, I mean, maybe this is too technical of a question. I think the real issue is about whenever, even though everyone is going to EPIC as an EHR, it's becoming more of a universal standard, and OCHAN mostly supports EPIC as their platform. When you go live with an EHR, like we're doing at San Francisco General right now, then you want your own customization, and you don't want to give it up to be a part of it's all these other political battles that come into play. However, I think the bright side of that, even if we don't go on to OCHAN, the share everywhere, the care share everywhere, whatever it's called with an EPIC as the platform is actually a pretty good sharing platform, whereas EPIC didn't used to have one. So I think that the ability to share EHR data is actually not a technical problem. It's really a political problem of sharing data, and I think we're getting there, but we can share the data. It's just, and they can, the fields are able to be matched, especially if you're on EPIC. And I think we should become the advocates for more of that too. I mean, I think there are talks of the leadership of doing that, but I think if you think about it from a public health standpoint, that's the use case for doing it. It's not necessarily always a billing or a competition. It's really a public health question at the end of the day to me. Oh, one over here.
Yeah, two comments. One is that, as I'm sure you're aware, there is a statewide data source that is representative, the hospital discharge data, the ambulatory care data, and the ED data set. The very valuable, very rich data has indicators, has many fields for all the conditions you were just looking at, but the only geographic granularity in that data set that's available to almost, well, that's even collected, is zip code. And you demonstrated very clearly there why that's not a useful geographic level of granularity. And I, over the handful of years, have encouraged people like health officers in county health departments and others to advocate for that system to just be modified, in a sense, slightly, to include granular geographic identifier. It wouldn't even have to be long-lat. You could get down to, as you've shown, census tract. And for whatever reason, it just hasn't happened. It's in this day and age, it's a minor modification to the system, but there hasn't been the policy will for whatever reason. And it seems like if academic partners could encourage that and demonstrate why that would be really useful, that could be available to all. It doesn't answer everything, of course, but it is statewide and representative. Other question I had was, the maps you show that are great, are they available publicly in some sort of interactive, queryable format, presumably?
Yeah. Well, you're reading my mind, because in the second year we're going to be creating some interactive web tools, so stay tuned for that, but not right now. We just launched our website, pophealth.ucsf.edu, that Kirsten mentioned earlier. These maps aren't on there yet, but they will be in some form in the near future, and then an interactive website is coming later, so that's the easy question first. The first question about whether or not lat-long or census tract identifiers are available in more publicly available data, like OSHPD and others that you're alluding to, I think and Hassan knows this better than I do, but I think that data is extremely valuable. I think the issue, even at the UCOP level, so not even thinking statewide repository levels, is that it's very identifiable, right? Lat-long is an identifier, it's PHI. How are there ways, I think there are creative ways to actually share some of those information, to scramble that information, to create fake identifiers for a census tract, the same way that we create fake identifiers for medical record numbers, things like that. There are ways to do it. I think, again, we need the will to push forward to actually advocate for that and do it. And I know Mahassan believes that piece of it, because she's the one who taught me about that, but I don't know if you have any other thoughts about that.
That was great.
Great. Oh, was it one last one.
Just a quick question. I was very intrigued when you mentioned that there's interest to use this from an operational standpoint in the health system. It seems like a great opportunity, but could you say a little bit more about whether that's going on or kind of what the process is for making that happen?
Yeah. So still, I mean, our initiative is only about 10 months old, so it's still, all this is pretty new. But as part of Kirsten's role, particularly as a vice dean for population health equity, she actually helps sit on our Office of Population Health and Accountable Care at UCSF Health. And so we've been presenting back to them about what kinds of focus areas we have, what kinds of maps we've been creating, and learning about what they're focusing on and learning about. So several of these have natural overlap. Aging, opioid use, obviously, are things that they're concerned about. So it's more in a conversation stage, but we chose our areas because of their feedback, and then we feedback what we found to them so that we're not going too far down an academic path, too far down a path that they wouldn't be interested in, essentially. And hopefully it'll be more formal and coordinated as we move forward into the next phase.
Great. Thank you all.
All right, so we will transition right into our last session, focused on non-traditional data sources and tools for population health. First, we'll hear from Ziad Obermeyer, Associate Professor in Health Policy and Management on machine learning and applications to clinical questions. And second, we'll hear from Urmimala Sarkar, Associate Professor at UC San Francisco on the topic of social media for population health. So I've been looking forward to both of these talks. So I hope you all have too. So thank you very much.
Sorry, Jen, you've already heard this one, so you don't need to look forward to it anymore. Thanks so much for having me. I'm Ziad Obermeyer. I'm at the School of Public Health. Let's see if my clicker works. So I'm going to tell you a story, actually, about a particular algorithm that some of you almost certainly are either familiar with or use. So when we think about all of the exciting new developments in machine learning and data and healthcare, I think we generally think about a specific kind of very futuristic thing, which is early warning systems to detect disease that isn't there yet, diagnostics that see microscopic details in complex health data that doctors can't see. And so I don't know if any of you saw this paper. It was a couple years ago. This is a paper that looks at pictures of skin moles and is actually a neural network that's able to distinguish benign findings like SKs from melanomas. And I think even though it wasn't mentioned in this paper, there's a lot of reasons to look at algorithms like this and worry that things could go wrong. So it doesn't take a lot of imagination to see that an algorithm that literally looks at the color of someone's skin might build in some things that we don't want to build into algorithms. I'm actually going to tell you about a totally different kind of algorithm today, though. Not because these aren't interesting, but because these kinds of algorithms are actually already deployed at very large scale in almost every healthcare system and accountable care organization in the country. And it's affecting decisions for tens of millions of people every year. And the reason for that is because these algorithms are responding to a totally different policy environment over the past couple of years, which is population health, which is something that's familiar to all of you. So as health systems struggle to move from a fee-for-service world where you just treat the patient in front of you to a world where you have to manage the health of millions of patients, you need to operate at a very different scale. And that's why algorithms are going to come in, as you'll see in a second. So one of the overriding focuses of this new world, of course, is a focus on cost savings. And so we know that as health systems are incentivized to cut costs while maintaining quality, they're increasingly focusing on the small number of very complex patients that are responsible for the majority of these costs. And there's a lot of thought that many people in this room know much better than I about how to improve the interface of those patients with the healthcare system. But if you look across lots of different healthcare systems at what health systems are doing, the unifying theme of almost everything is around care coordination, high-risk care management, whatever you want to call it. It's a set of programs that do a number of different things. I'll summarize quickly since most of you already know this. But what these programs do is they set up almost like a VIP program for these very complex patients where when they have a problem, they just call sometimes a dedicated number. There are trained nurses on staff that help that patient with any problem they might have, from filling medications to getting a slot with your primary care doctor. And so overall, the evidence base, while some of it's mixed, it's generally positive. And so when we look at how these programs do, they generally seem to help these very complex, medically complicated patients get the care they need. And by doing that, by having people call, get in to see their PCP, get a medication that they otherwise might not have gotten, they're helping to avoid these burdensome outcomes like ER visits and hospitalizations that patients don't want, and also save the costs that nobody wants to pay. And so it didn't need to be this way, but it so happens that these programs look like they're actually doing well for both the patients and also for the healthcare system. So where do algorithms come in? Well, these programs, as you can imagine, are expensive. So there are trained nurse practitioners, there are extra slots in primary care clinics, so these are scarce resources. And that is where the algorithms come in. So you can imagine if you're the policy planner who's dealing with a population of patients, you need to figure out which patients need these programs most. And when you've got millions of people, and when nationally we've got hundreds of millions of people that we need to sort into these programs, most healthcare systems are turning to algorithms. And so these are industry estimates, but by this industry's estimate, there are about 150 million people whose lives are affected by algorithmic decisions about these programs every year. So these programs find those patients with complex needs, and they generally do that by saying, okay, I'm standing at a certain time. I'm going to predict next year which patients are going to be accounting for a lot of these costs, and I'm going to find them today. It's the general approach. So in our example, we're going to use an algorithm. It's a commercial algorithm trained on a national data set, and it's applied to a large primary care practice that's 12% Black. There are a lot of different ways to look at bias. We're going to focus on the consequences for program participation. And so concretely, the algorithm score is used to screen for program enrollment. And at the 97th percentile, people are automatically enrolled in the program, and at lower percentiles, they're screened. So we're going to look at a variety of health measures as a function of algorithm predicted score, and we're going to compare Blacks and whites. Some basic data about comorbidities in this population. We're going to first look at the total comorbidity burden over the year for which we're making predictions. So this is the algorithm risk score percentile on the x-axis. This is the comorbidity score, so active comorbidities that were encountered over a given year. The top line is Black patients. The bottom line is white patients. So you can see that at any percentile of that algorithm score, Black patients are less healthy on average than white patients at the same score. At that auto-enrollment threshold, it's about a 28% difference. And we can quantify that by doing a simulation. So we can zoom in here, and we're going to say, okay, we're going to take the least healthy white patient that was allocated into the program. We're going to take that person out, and we're going to add the least healthy Black patient who was not put into the program at this auto-enrollment threshold. And we're just going to keep doing that until we find two patients that have the same health. If we do that, we would more than double the fraction of automatically enrolled Black patients. So this is not a small amount of bias. This is fairly consequential. So that's a comorbidity measure that's based on billing data, but we also have biomarker data. So for all of the most common illnesses, this is the fraction of clinic visits where the blood pressure was uncontrolled. Black patients much worse than whites. These differences correlate to big differences in risk of heart attack and all-cause mortality. We can do it for hemoglobin A1C. Again, Blacks much less healthy. This is anemia of chronic disease, perhaps. This is the difference at the auto-enrollment threshold. It corresponds to about a 14-year age difference. This is creatinine. So I can keep going, but on all of the biomarkers that we look at, Black patients at the same risk score as whites are substantially less healthy. So you might wonder what's going wrong. And one clue about what's going wrong is where the algorithm is going right. This is the algorithm risk score, and on the y-axis here, instead of health, is cost. And you can see that for cost predictions, these predictions are lining up very well. So the algorithm is doing a great job of predicting costs for both Blacks and whites. The problem, of course, is that at a given level of health, measured by chronic condition or whatever, Blacks actually cost less, on average about 40% less than white patients. Now the channels of this could be any number of things. All these are insured patients, but I don't need to tell you about the many financial and logistical barriers that Black patients face, as well as very different interactions with doctors, as a number of recent randomized trials have shown. So in summary, if we want to predict cost accurately, we will underpredict health for Black patients. And that means that when we're allocating this program, healthier whites are getting ahead in line of less healthy Black patients. Now, the proximal cause of that was the choice to predict cost. But, what's the deeper cause? Why was cost chosen? So there's one story, which is kind of, the obvious one, which is, well, just follow the money. Actually, hospitals and insurers do care about cost. And society, sure, we also care about cost, but really we care about health. And so this difference between health and cost prediction is just a mirror image of all of the other externalities that we see in our healthcare system that arise from this difference between profits and patients. So that's one story. But there's another story, and I'll try to convince you that this is the right one. And this story is about learning. So if you think about how you talk about healthcare needs, certainly how I talk about healthcare needs, I often find myself slipping and talking about healthcare costs. That actually makes sense because health does actually correlate with costs on average. And it's also very convenient to predict costs. So you saw how many different measures of health I had to show you to convince you that Black patients were less healthy. Cost, when you're in data cleaning mode and you're just looking for an outcome to predict, boy, cost looks good. It's very appealing. So how do we distinguish these two? So we can do a couple of thought experiments, but I'll tell you maybe as an epilogue to this story, the most persuasive evidence that this is the right one. This might have been obvious to you guys, but it wasn't to us. So we finished this paper, and then we thought, well, maybe we should just contact the enormous company that makes this algorithm and ask them, hey, have you guys noticed this? So we did. We just emailed them. And they were super responsive. And they wanted to work with us to try to understand the problem and fix it. And they immediately put their technical team to work to first replicate our findings in their data set to make sure we weren't doing something crazy. But when they found it, they actually were really interested in working with us to try to fix this problem. So we're working together with this company to develop methods to adjust the algorithmic predictions. And early results indicate that we're doing really well reducing the bias. So by their measure that they've chosen, their original algorithm was producing about 50,000 excess chronic conditions in Black patients versus whites across the risk distribution. By modifying the algorithm, we're ending up with only about 8,000, so 84% less by that measure of bias. And this is turning into an ongoing collaboration, and I think for me, this is a hint that that learning view is more accurate. So just to summarize, we found a fairly large amount of racial bias in this very widely used algorithmic prediction that resulted in less access to an extra help program for Black patients. And the root cause of that was cost prediction instead of health prediction. And I'll point out what you guys have already realized, which is that the original algorithm did a lot to reinforce structural inequalities and everything we don't like about our health system. People who spent a lot of money last year are going to spend a lot more money this next year. And fixing that didn't solve any of those underlying structural problems, but is actually built on understanding them and working to reverse them. Thank you.
Hi, Maddie Deutsch from UCSF. I'm wondering what your trick was to get this manufacturer of an algorithm to, I mean, was it as simple as you sent an email and they said, wow, great? Because I am leading the adoption of SOGI data collection at UCSF Health, and I've tried to work, many of us have tried to work with Epic over many years and we get nowhere. So, I'm just kind of curious, was it that simple or did you do more or what's your trick?
It was literally that simple. It's not Epic, so it's a different company. So we had that going for us.
I remember that in American Association for Artificial Intelligence conference in the last year and also this year, January, they are really focusing on more machines broadly, which means that they also wanted to reduce all of the bias or inequalities that are caused by general algorithms. So I was wondering if you have any plan to introduce what you're doing here in healthcare in order to, to broader audience in the AI conference or AI field.
Yeah, thanks for asking. Yeah, we did present this at the kind of premier computer science conference on fairness and transparency in algorithms. And I think the interesting thing, at least for the computer science people who work on this, is that the cause of this bias is very different from the causes that a lot of other people talk about. So the things people talk about are, the training data is not enriched enough for the minority population. That's not it. We didn't change the training data to fix this problem. The algorithm was using the race variable. The original algorithm did not use the race variable. Our modified one does not use the race variable, so that's not it. What it is we found an outcome measure to predict that was not biased, and then everything else goes away. And so I think it's very appealing in that way because it means you don't need to do a lot of new data collection. You don't need to do a lot of orthogonalizing all of the predictors against race. you actually just need to put some thought into picking the right outcome and making sure that that's not biased.
Hi, I'm Meredith Meacham from UCSF. Thanks for that really illustrative example. I'm wondering about how these algorithms might take into account when someone receives targeted resources based on their percentile and then actually improves on whatever measure, and then they wouldn't fall into that cutoff, and then do they lose those resources or do they retain them?
Yeah, it's a great question. We actually originally got this data to look at those kinds of effects and try to estimate the program effect. Here, practically, we didn't find any program effect on those particular biomarkers, and so we don't think that this is an artifact of differential treatment or differential successive treatment. In practice, I think what you'd want the program to do is when people get genuinely healthier, you would actually want them to not be in the program anymore, to make room for someone that actually needs it. And the trick there is, of course, picking the right measures so that the thing you're screening on is actually the thing that you want to be screening on, to make sure that you're getting genuinely unhealthy people in the program. And when people get healthier, they don't need to be there anymore.
Always a delight to be back at Berkeley, where I got my master's in public health some time ago. I am delighted to be here to talk to you about social media data and public health. It's very interesting to me that my Berkeley colleague presented something that is actually much more rooted in the healthcare delivery system than what I'm about to share with you, and I think that's very much a testament to the breadth of the work that we do on both sides of the bay. All right, so let me just dive right in. So I'm going to tell you why I think we should talk about social media in the context of data science and population health. I'm going to present to you a very practical conceptual framework, and I'm going to give you a brief example with time for questions and time for people to immediately zip out for lunch. Okay, so when I'm talking about social media and health research, the broad idea is that we're talking about transdisciplinary research that utilizes online social media data, platforms, or networks to improve or inform health. That is a broad definition, and I hope by the end of this talk I will have justified it to you. Okay, so this is the slide for the people who are not so convinced that social media is actually relevant to health. Lots of people use social media. Many people use social media as a primary source of health information. There's good evidence that it influences health behaviors and decision making. Okay, I'm not going to say any more about that. So this idea of social media is really predicated on the idea of multi-directional interactions over space and time among different constituents. So within that overall framework, I want to just describe very briefly 3 types of ways that this comes into play and how this relates to data science and population health. Okay. So one way in which social media has been harnessed to try to improve health is through online interventions. And these are sort of translations of existing health interventions, such as smoking cessation programs, into the online space. I don't view that as really key to what we're talking about today. I want to mention that it exists, and I want to put that aside for the rest of the talk. Okay. Another way in which social media has been used for health and health research is to think about public health campaigns. So one of the foundational aspects of public health is that billboard that tells you to eat your vegetables or not to smoke or something. And that has also been moved very much into the space of social media. And we can see that there are many advantages to using social media for that kind of unidirectional mass public health campaign. So I'm not going to get into this in depth, but I want to share with you what I think some of the potential for this is, because it does have a data science element. So some ways that you can actually do a public health campaign, such as a vaccination campaign over social media, that would be an improvement over what we've always done in traditional public health, would be it's feasible, right? It's inexpensive. It actually costs less to deliver messaging over social media than it does by by purchasing it in traditional advertising. You can be targeted. So there's a lot of scope using AI, as we were talking about, to understand who is where on social media, and that can allow you to deliver appropriate and targeted public health messaging. Again, you can use data science not just on that targeting side, but on the analytics side to try to see what the engagement with your public health messaging is. You put up a billboard, you don't really know how much people notice it when they're driving by, but you can look at likes and shares and click-throughs on social media and understand some of the impact. Now, there are some caveats around that. And then I will say that there is a really pernicious element to social media messaging vis-a-vis public health, and that's that there are very pervasive anti-public health messages on social media. So vaping is a practice that has gained a lot of currency using social media. In recent policy debates about, for example, the soda tax, we have seen big soda really effectively use social media to try to harness and increase opposition to the soda tax. And then anti-vaccination messages get a lot of play on social media and have been tied to decreasing vaccination rates of communicable diseases. So all of those things are very concerning, and the tools of data science are really important for both delivering and evaluating the use of social media for public health campaigns. So I'm going to stop there and then talk about a third kind of social media and public health research. Okay, so another thing, we've been talking about data all morning, right? Everybody's talking about all different kinds of data, and social media content is data, right? So what kind of data is it? Pictures, text, locations, right? So interactions. So all of that data, it's individual level, it is community level, and it is varied. And we can, as public health experts, use this data to make some inferences and come up with some health and behavioral insights. So I want to give you one example that is not data science, but it is related, it's data science adjacent, about what we can learn about public health behaviors using social media. Okay, so I, as a primary care physician, am really interested in opioid use and misuse. And I first did a study where I looked at Twitter, which is a short text-only platform. This is before Twitter got to 260 characters, or 280 characters. It was the 140 characters. And I did a study looking at what people were saying about non-medical use of opioids. They were just posting about taking Vicodin and vodka together on Twitter. And I did a study of that. And then I got really interested in, as younger people moved to Instagram, which is really an image-based platform, could we understand the epidemic of opioid misuse among young people using social media? So I tried to use the hashtags from my prior Twitter study. And what I learned can be summarized on this slide. Instagram is a drug market. So if you enter a hashtag followed by the name of an opioid medication on Instagram, you can find out where to buy it. While that is a very important and public health relevant finding, from my clinician investigator perspective, it wasn't what I was going for. And I bring this up because it's really important, and I hope one of my take homes to you is you must be platform relevant, right? So we were looking on Instagram, and we decided that we would go back to the drawing board a bit and try to understand what people were doing in a different way. So what we learned is we could focus on coding, right? While most of the content about other medications was pictures of pills, there was a lot of imagery about misuse of codeine. Can I have a show of hands of who knows about misusing codeine cough syrup? Okay, so I'll tell you a little bit more about it. Codeine cough syrup is commonly combined with soda, sometimes with hard candy added, and consumed in layered styrofoam cups. This type of use is tied to a very specific subgenre of hip hop music called trap, and has a lot of currency. It started in the Southeast in Atlanta, and it's a specific subculture that isn't at all about this, but this is a substance use combination that is associated with a specific set of other images, iconographies, celebrities, etc. So just to tell you a little bit of the data process, because we were at a data talk, I started with these hashtags on the left from a prior study of Twitter. Then we looked at a whole bunch of Instagram posts and said, okay, well, we're going to focus on codeine. Then we looked at what we came up with and looked at all the hashtags and said, okay, some of these relate to misuse of codeine and some of them don't. Then we found that led us to a secondary set of terms that we looked for. And then once we had enough terms, we sampled randomly from the images, from the posts that had one of these terms, and then did a content analysis where we, in an inductive fashion, right, so without preconceived notions about what we were going to find, we looked at all of the text and all of the images. Okay, so this is a word cloud. The size of the text is related to the frequency, but the placement is just what it is. It doesn't have any meaning. And these are some of the things that we learned. So you can see a couple of salient things that are not really widely discussed. One is there's certainly it's known that there's co-use of marijuana with codeine. Interestingly, you can see the word Actavis is not, let me see if I can point this. Yeah, Actavis is not small, okay? Actavis is, it's a stimulant medication that's prescribed for ADHD. And the co-use of stimulants and codeine is not commonly discussed, but it's certainly extremely concerning. These terms, purple drank, walk heart, cough syrup, and lean are all used for this combination of soda and codeine. And then you can see, let's see, there's a lot of cultural reference here. And I think this is really germane to prevention of opioid misuse, because you can see what are some of the things that are appealing to people about this opioid misuse, right? And this idea of luxury, money. There are the names of several rappers here. Those cultural concepts and cultural reference are going to need to be taken into consideration as we think about preventing this type of misuse. I'll also point out that I gave this talk before, and one of the audience members told me that this rap group, ASAP Mob, which I will admit to you I'm not familiar with, is actually extremely anti-drugs, and that's probably why they came up. They had someone in their circle who died of an opioid overdose, and so post a lot about the potential consequences of opioids. I bring that up to you because it's a really important limitation of doing this kind of analysis. Is you might see something come up very frequently, but you have to know what it means, right? Okay. So what do we get from doing this type of work? It has some advantages over, for example, the youth risk factor behavior survey that comes out of CDC, because it's real time or close to real time. You do have a sense of the geography. Not all social media posts are geotagged. You can't always figure out where everyone is, but you can look at them and look at how they spread and get a sense of how that happens. Younger populations and non-white populations are more likely to use social media than older and white populations. So sometimes you can get hard to reach populations and stigmatized behavior that people are not coming into my clinic and talking to me about, you can learn about on social media. Emerging issues surface that a survey or another metric of behavior may not capture because people might not have thought to ask about that particular behavior on that year's iteration of the survey. So there are some challenges and next steps that I want to leave you with. Well, as a next step, what I did was all manual, right? That's why I said it was data science adjacent, right? Because it required people doing traditional qualitative analysis. In contrast, what we've done with this data now is we've turned over all the images to a computer scientist based at UNC who saw our paper and contacted us and said, can I have your data? And I've actually done this on a couple of other occasions with computer science colleagues. And then she's using this hand-coded data as the basis for creating an algorithm that does automated image analysis. So the type of work that I think of as pretty deep and narrow can actually be expanded out with the right collaborators to then look at a much larger sample of data and draw many more inferences. I'm going to submit to you that I don't think this can all be done in an unsupervised way at this point. I think you need, early in the process, human-trained public health professional eyes to help understand what we're seeing. There are challenges that Will alluded to some of them at the very beginning of this. One is representativeness, and I know this may actually be the most controversial thing I say, but I do not think representativeness is the be-all and end-all. We can learn a lot about populations that need intervention, and even if what we're finding doesn't apply to everybody, if it informs a future intervention's effectiveness, I think it's still worth doing. The second thing that comes up a lot in the work that I do is who is actually posting this stuff? Is it an actual person? And obviously, I would be overstating it if I said that we can tell, right? We can't really tell who's a bot and who's a person. But my colleagues who are data scientists have a number of approaches to try to address that using computational techniques. And the third thing that I think should have really bubbled up by now from just hearing this example of my work is that this work, it can't even start if you don't have an interdisciplinary team. I feel like my perch in primary care at San Francisco General Hospital gives me a lot of insights about what questions to be asking, and then traditional EPI methods like qualitative research can really take this work to a certain point where you do get some new insights. And then to take it to the next level, you need to bring on people with a very, very different set of skills. So I hope that these are some of the take-home points that you get from today. I think there's a lot of potential for taking this morass that is social media data and turning it into actionable public health research. It's a potential data source for disease surveillance. I think many of you, I didn't put in the example papers about flu and social media posting because I think they're sort of old hat to all of you guys by now, but disease surveillance, reporting, and forecasting are things that are all being done in practice right now. It seems to me like a useful vehicle for unidirectional public health campaigns. People use social media for recruitment of patients to online studies and clinical trials. There is also sound evidence for contagion of behavior via social media. And so to the extent that we can harness the interactions that people have online in order to promote positive health behaviors such as vaccination, social media holds a lot of promise. And like it or not, this is where people live in 2019. So either public health professionals, data scientists, physicians and health systems get onto this space, or we cede this space to actors whom we do not want to cede it to. Okay. If you are interested in this topic, we have a symposium at UCSF in December that many of us are on the planning committee for, and we'd be delighted to have you. So thank you very much.
It's great that you identified some rappers or songwriters. They posted their songs on the social media promoting drug use, and I heard rumors that some pharmaceutical companies, they actually paid money to those songwriters in order to promote those drugs. So I was wondering, in terms of public health intervention, what can be done towards the pharmaceutical companies who is doing this?
I think your question has a larger relevance, which is everybody's on social media. So how can we make our voices heard, and how can we make sure that unhealthy messages are appropriately transparent and or not shared? And this, I think it's a dialogue with the platform providers, right? And I'm going to just echo what Ziad alluded to earlier, in that I don't think that there are bad actors, right? There are tobacco companies. But there are lots of people who really believe that tech is going to save the world, and that they really believe in the power of their platform to do good. So I have had pretty good success in partnering with people to at least discuss how can we elevate public health messages on a number of public social media platforms. I think transparency is really, I mean, they say sunshine is the best antiseptic, and I think transparency is really the way that we're going to get this. And we're not going to get it from those bad actors, right? So I think talking to the platforms who are really like the highway infrastructure of this new world is the right way to do it. And I think you all should be participating in this space, right? Don't give it up because it seems intimidating and potentially fraught.
Tomas Aragon, Health Officer, San Francisco. Thank you very much. Very exciting. I can tell you that for us, this type of work has been really useful. So we were designing a campaign for PrEP for HIV prevention, and we had a consultant that specialized in digital ethnography, and they were able to uncover all these things that we would never find in any research paper. And it was tremendous in terms of really crafting our message in language that was actually being used by the community in real time. And so it really transformed how we think about this. Thank you very much.
Thanks for sharing that. Yeah. Great. All right, well, I won't stand between you and lunch any longer. Thank you.
Oh, great. So we're a little over schedule, but we have actually have a couple minutes, and I wanted to make a few announcements and then hear from you all in the last few minutes. So the first is that we sent out an evaluation right now, about 3 minutes ago, in your email. So if you could please fill it out. If you could do it now so you don't forget, that's why I'm telling you right now. I would really appreciate it. It's related to what I'm about to ask you, which is about directions for the future. So I think we were going to hold time up here to take questions and to do some facilitation, but you guys were actually a very great audience in asking questions, so I'm feeling like we got a lot of feedback about ethical implications, about data sharing, community and public partnerships. Some of those are the kinds of themes that I heard. And so I'd love to hear from you all about where, if we wanted to partner more in population health, and specifically methods like data science methods for advancing population health, what are the kinds of things that you would like to see in the future? And it could be convenings like this, but it doesn't have to be limited to meetings. So I really encourage you to think through what are some of the major problems that you heard addressed today that you wanted to tackle? What are methodological things you wanted to, those are the kinds of things that I would love feedback from this group, both on the survey and now if you have them off the top of your mind.
Jen. So maybe this is unnecessary since I'm part of the planning group, but one struggle we've had with our big data types of projects is thinking about I guess we heard a lot today about the importance of having practical, actionable results that would lead to policy change, for example. And that, sort of relies on a causal interpretation of what you've found. And we have done a lot of work trying to figure out which designs can be used effectively with these kinds of data sources, because they are not the traditional cohort sort of thing we think of as a big primary data collection survey. And so I would really benefit myself from learning more about what designs people have found to be effective in drawing strong inference from studies using these kinds of data resources.
My name is Saul Kanowitz. I work at the California Department of Public Health. I guess a question I have is the resources to, as research and surveillance moves to electronic health records, just the cost of managing these electronic health records and manipulating them, customizing them for the purposes of research, at least from my back office data person point of view, is becomes almost somewhat of an obstacle to collecting the data that you want for the purposes of public health surveillance. So just, the resources and how do you manipulate these huge systems in a way that you can get data in a timely fashion that's effective, and then, of course, addresses kind of the cross-collaborative issues of the many different subjects that came up today.
So is it fair to say that you're suggesting more sharing of how we've manipulated EHRs between systems, or?
How to access resources to make the data systems more flexible and timely respond to research and surveillance.
Yeah, that's another one that didn't come up today, actually, that I think is really important. Working in a safety net system and looking at the EHR there and the types of EHR that we were able to purchase in the past and ones we are able to purchase now are very different than other systems, and how to, even the data infrastructure needs to be able to pull the data is very different. Yeah. Sure.
I'll put in a word for this, which is that we all are beginning to, or probably well on our way to knowing how difficult it is to get all this diverse and the diversity of data we need. So I'll put in a word and say that those that do get it for your research/collaborations, please give a thought to a data use agreement where it allows for more wide sharing beyond your own research, often from public sources. If you could do that, then that would benefit a pretty wide, set of people. Just give it a thought. Thanks.
I think examples of data use agreements might also be another finding. Do you want to get on the mic, Jeff? Yeah. I would call on you, but then want to record it, Rita.
So I was going to mention two things. One is that I think another challenge is funding the types of data infrastructure that we need. At UCSF, we're just getting started on this population health data initiative, and we're realizing that the servers we have maybe aren't up to snuff for some of these large data sets that require a lot of computational power, and getting the resources, that like a single funder might not be interested in building the infrastructure for the entire university, how to piece that together. And the other thing, if you don't mind, I was going to mention the other major resource. I'd be remiss if I didn't mention that on this new pophealth.ucsf.edu website, one of the things that we've done this past year is put together a database of lots and lots of these big data sets, survey data, claims data, administrative data, so that people should look to that as a resource. And it includes new data set acquisitions that we've made at UCSF, including, for example, getting a subscription to the Berkeley Restricted Data Center that has a lot of these restricted census and National Center for Health Statistics data sets. So people can look to that as a resource, and there's also links on there if you need statistical consultation or a consultation on finding the right data set, et cetera. So, yeah.
Great, let's take one more, and then I have a few closing things.
Tomas Aragon, San Francisco. So in my fantasy world, in the same way that a medical student does a residency and rotations and residency through Zuckerberg San Francisco General Hospital, that we would have students do sort of these practicums at local health departments where it would be a win-win, because we could never afford to hire the full-time staff. It's never going to happen. But we could probably find money to contribute to a training program where they're getting frontline practice, and we team up with computer scientists from SF State and us, where they do the equivalent of what residents do in medicine, but rather population health data science.
Great training, I love that. Well, I really appreciate such great engagement today. I want to thank all of the speakers for their wonderful talks and different ideas about data. So I know I took a lot of data ideas for the future out of today. I wanted to remind anybody who didn't sign up with their email address in the lobby when they checked in to please do that. We're going to obviously hopefully create a listserv or at least some communication about this event in the future for everyone who attended and has had a lot of interest in this topic area. We'll also be posting the recording and the presentations from this event on a website later, and we can email you when that is live. And then, of course, the last thing I wanted to say is I just wanted to thank, I know we didn't have time, we were going to have the entire steering committee up here to do the closing remarks, but since we had such rich engagement, I don't want to delay lunch any further. So I wanted to give a special thanks to Elizabeth Brashears from Berkeley and Jessica Fields from UCSF for their wonderful organization of this event. I also wanted to thank the steering committee, so Jen Ahern, Rita Hamad, and Mahasan Mujahid, and myself, who put together this content just to try to move the dialogue and meet each other across campuses. So I really appreciate your attendance and hope to talk to more of you out at lunch. Thanks.